webinar on focusing on interventional EUS. So previously we had several webinars in biliary drainage, gastrojejunostomy, as well as EUS specific stents. Today we're going to focus on endoscopic treatment of pancreatic fluid collections. And thanks to technology, once again we can have the very blessed number of world-renowned international faculties who will be sharing with us their experiences in management of this condition. In terms of registrations, again, we have a very good number, almost more than 700 participants from all around the world. From our previous experiences, we found out that time zone, which is now 8 p.m. in Hong Kong, is the best for everyone around the world. So in US, it's 8 a.m. In Europe, it's around noon, and it's on Saturday, so it is a very good time. In terms of participants, I just got the stats. I think we have everyone from around the world, from India, Spain, Hong Kong, Thailand, to Mexico, Singapore, Saudi Arabia, UAE, many countries in Europe, and so on. So we are extremely happy, and hopefully everyone can learn from all the talks tonight and have a very great discussion. I'll hand it over to our president, Lawrence Ho of the Asian EUS Group. I think maybe we might need to change our name very soon. We are becoming more and more international, but right now we are still the AEG. So thank you, Lawrence.
Oh, thanks, Anthony. So I would like, basically, I think because we have a more international audience, each time we organize such webinars. So I'm going to take the opportunity to introduce the Asian EUS Group to the audience as well as the faculty who are joining us today. So perhaps I think many of people may not be aware that there's this group, which is called the Asian EUS Group. And obviously, I think Anthony is the very active member of this group, and he's also one of the pioneers in many different areas. So I'm actually going to just briefly introduce the group on behalf of all the members of this group. Essentially, the group was formed way back in 2012 with only one singular goal. And the goal was to promote the adoption of EUS through training in the Asia-Pacific region. And then over the times, we have actually evolved to come up with certain workshops. And I just like to kind of highlight, I think the success of these workshops is chiefly due to the three key features which we have actually been adopting in most of our workshops. And the three key features will be, again, I think briefly described in this so-called memory lane, which we have actually traveled together. Many people, many faculty members have actually walked this lane together with us since the beginning in 2012. So over this time, we have organized many workshops in different countries in Asia as well as in Australia. So it's organized by the local people. And then we basically support this organization through the faculty. So I think in total, I think more than 130, and then more than 4,000 doctors have been trained. And many of these workshops, as I mentioned, they adopt this hands-on feature. So there's hands-on training, and using either animal models or the so-called ECOMA models. We also incorporated so-called feedback as well as assessment to make sure that I think both the trainers as well as trainees are effective in these training sessions. And over time, we also have cater for different so-called needs, because I think as people become better, I think they want to be trained as trainers. So we have organized this so-called train the trainers courses in certain centers of excellence. So one of which is actually Anthony Center, which is in Hong Kong, where the small group of more advanced trainees will be trained over 1 or 2 weeks period. And more recently, I think, as we know, I think interventional EUS has become an important component of our daily practice, and we have started organizing these workshops. Obviously, I think these sort of procedures are more high risk, And that's where the sort of the different groups within Asia have come up with their own training models, and then which are all shown here. These are all in-house built, and then over time, I think they have come up to become mainstream, I think, models in many of the workshops. And then we have the biliary drainage models by different groups as well. And then I think people know about this particular consensus guidelines, which was written up by most of the members in this Asian AS group. So we are proud to say that this is the first consensus on interventional EUS in the world. So I'm sure Anthony and many of the faculty tonight or this morning will be actually sharing or even referring to these guidelines later on for the benefit of the other people who are our registrants who are tuning in today. So lastly, I just like to mention that I think we all know this year is extraordinary because of the COVID-19. And certainly I think we have to bear some of the so-called, I think, disadvantages, including, I think we cannot organize hands-on workshop anymore, and we can't do this assessment. But on the other hand, we also have continue to come up with new ways of running the courses. And this is where I think this is something that I think between Anthony and Renee, they've initiated this so-called monthly webinars. Okay, so the first one was held in July, and since then they've been doing it almost every month, alternating between India and Hong Kong. And again, I think the advantage is for webinars is we can certainly reach out to a bigger audience with, as I mentioned, I think you can see the number of registrants and the number of participants from the number of countries is actually a lot. I think it's quite a lot. And I'm going to take this opportunity by finishing to say that I think we certainly like to thank many of the collaborating societies, okay, over the time who I think our faculty from different societies such as the European Group for EUS, the Columbia Association of Endoscopy, the Gastroenterology Society of Kenya, the Saudi Gastro Association, and some of our colleagues from USA who have been really very helpful and participating in this sort of webinars. So with that, I really like to congratulate Anthony for this, I think, very laudable effort to try to continue, I think, this sort of training despite, I think, the current pandemic. So thank you, Anthony. I think I'll hand over to you to introduce some of our OC speakers.
Okay, thank you. So thank you, Lawrence, for mentioning just now our co-organizing societies, including the EGUS, Claudia. Claudia is not here. Lazaro, thank you very much for organizing, co-organizing all the way from Colombia and also arranging all the translation. Also, we have Ellie, Professor Ellie, who is with the Society of Kenya. So today we are very excited to have all of you helping us co-organize this webinar. So first off, we have a number of stellar speakers tonight, including Todd Baron, Shyam Varadarajulu, Sundeep Lakhtakia from India, Yousuke Nakai from Japan, Marco Bruno from Netherlands, as well as Professor Kelvin Ng from our own university. So I think I'll hand over to Lawrence and Professor Yasuda, and then perhaps you can start the first session.
Okay, certainly. So I'm Lawrence. I think I was introducing the AEG just now. I hail from the National University of Singapore. So it's my pleasure to co-chair this or co-moderate the first session with Professor Ken Yasuda from Japan. So he's a great advisor to the Asian US group. So I'm going to actually, between us, we are going to share our moderating tasks. I think maybe I will do the first task. I think if Ken doesn't mind, I'm going to introduce our first speaker from USA, Professor Todd Baron, who is really well known. as a kind of master EUS and ERCP. He comes from the University of North Carolina School of Medicine. And today, I think very, very happy and privileged to have him talk to us on the AGA guidelines on the management of so-called wall of pancreatic necrosis. So I think Todd, please.
Thank you. First of all, I'd like to thank the organizers for having me here today. Let me just get my PowerPoint presentation. It's an honor to be a part of this this program, especially. Let me just see. Hold on. Here we go. Let me go into the slideshow. Okay, and then share screen. Here we go. Good. All right. So share. Okay. Thank you. Yes, I'm going to discuss the AGA guidelines on management of walled-off pancreatic necrosis, abbreviated WOPN. Let's see, how do I advance my slide? So first of all, what is walled-off pancreatic necrosis? So walled-off pancreatic necrosis has been defined and was published in Gut by a consensus panel in 2013, January, as a mature encapsulated collection of pancreatic and/or peripancreatic necrosis that has developed a well-defined inflammatory wall. Walled-off necrosis usually occurs more than 4 weeks after the onset of necrotizing pancreatitis, although I would emphasize that there are patients that have organized earlier and some have organized later than that. And so that's a rough idea of approximately when we define and have walled-off pancreatic necrosis. By illustration, this is central walled-off pancreatic necrosis. As you can see, it usually occupies the pancreatic bed where the necrosis originated. It usually consists of some liquid component from leakage of pancreatic fluid from the disrupted pancreatic duct, as well as the incorporated necrotic solid debris. It obviously can extend into either the right or left pericolic gutters or both, but most usually is, again, central in nature. This is an image from our publication that I'm going to discuss, showing early acute necrotic collection without a defined wall early on, and a walled-off necrosis, as you can see on the bottom panel. And this is a patient of my own from actually several years ago that we performed endoscopic drainage. You can see a well-defined collection that's compressing the gastric wall. There's a little bit of enhancing pancreas that you can see. And you can see there's also some heterogeneity on this, reflecting underlying necrosis, because as all of you know, CT scan often underrepresents the amount of solid debris because it appears homogeneous. And in fact, MRI is a much better way of seeing the underlying solid debris. So in 2020, I was a lead author and part of a consensus on a practice update by the AGA that we're going to discuss today. This was done along with other gastroenterologists and an experienced pancreatic surgeon to provide these guidelines. So the review was commissioned and approved by the AGA Institute on Clinical Practice Updates and the AGA Governing Board. It was framed around 15 best practice points, although obviously I'm not going to go through all those points. And again, the authors are composed of endoscopists, gastroenterologists, and surgeons. So as an overview, the treatment approaches to walled-off pancreatic necrosis include medical and nutritional management, percutaneous drainage, endoscopic therapy, and surgery, which can consist of open necrosectomy, which fortunately is not being performed much anymore, but may have a role as a salvage procedure: laparoscopic necrosectomy and video-assisted retroperitoneal debridement. Again, I'm going to focus mostly on endoscopic therapy with a little bit of mention of percutaneous therapy. The choice of treatment approaches, and again, while we're discussing endoscopic, is really based on availability and expertise. Central versus peripheral necrosis. Obviously, the central portions are amenable to endoscopic drainage, and the very peripheral areas that often occur along the pericardial gutters may not be approachable endoscopically. The degree of burden of necrosis, these choices should be tailored to the patient, and keep in mind that an individual patient may require one or more or even several of these approaches to have complete success. I'll briefly mention percutaneous drainage as primary therapy. It really is reserved now for infected pancreatic necrosis because it can provide rapid and effective source control in patients that are very sick with infected walled-off necrosis. A small percentage of patients can actually do well with percutaneous drainage as monotherapy, but in my experience, that's really a very, very small percentage of patients. And as you know, it can be used as a platform to perform video-assisted retroperitoneal debridement by passing videoscopes through these percutaneous tracts for debridement. So I'm going to give you actually a relatively recent case of mine that was referred to me. Patient who was very, very sick, had infected necrosis, as the patient had actually an ERCP close to the onset of severe necrotizing pancreatitis, and a pancreatogram had been performed, which I think was the source of infection. You can see this very complex collection along the gastric wall. They were referred to me after 2 weeks of percutaneous therapy, and although the percutaneous drain improved, or at least temporized, the patient had reached a plateau where they were actually not responding very well. And so we went in actually just a few days ago, and you can see on the upper left panel, here's the echo view of this area from around the stomach that had the necrotic material in it, and the right lower is immediately after placing a 20 French luminal opposing metal stent. And in this particular case, I think it's important to realize that the percutaneous drain can now be used only for irrigation purposes to flush the necrotic debris back through the luminal opposing metal stent. And my feeling is this patient should do extremely well. So in terms of endoscopic drainage, it's performed by transmural stent placement. There is a feeling that some patients, many patients, might be able to do well with large caliber self-expandable metal stents, predominantly now using luminal metal stents by themselves. But in some patients, debridement methods are needed to resolve the necrotic debris. These include irrigation, and as I mentioned in that case, in the form of percutaneous drainage, but can also be nasocystic irrigation, direct necrosectomy, or a combination of these approaches. We'll hear from Shyam next about plastic versus metal stents, but I think it's fair to say that most of us have gone to using large caliber self-expandable metal stents, predominantly LAMs, because of their ease of placement, again, also because they're large diameters. Endoscopic therapy has become the mainstay of therapy for walled-off necrosis. We mentioned use of luminal metal stents that have simplified the drainage approach, and the technical ease has been simplified using cautery-enhanced stents. They can be very, very quickly performed. We advise using, and again, the guideline we recommend that I'll discuss uses a step-up approach, as LAMs alone can provide resolution in a reasonably high number of patients, and reserve direct endoscopic necrosectomy for patients who do not adequately respond to LAMS placement alone. So I'm going to present a case, also a relatively recent case that we had. Here is a patient that had infected necrosis. You can see on the left upper panel, there's a component that's close to the stomach. The middle right panel can show you that there's this component toward the duodenum, and the lower middle panel exemplifies that a little bit more. So in this particular patient, who was actually quite sick in the intensive care unit, we actually went transduodenally for the first LAMS placement because we thought that although these obviously communicate, they may not communicate adequately enough to allow one stent to resolve both collections. And then we proceeded to do a transgastric approach. This stent in the pancreas had been there prior to our intervention, and this time we left it in place. So both transgastric and transduodenal in the same approach, and doing nothing more, no other interventions. The patient dramatically improved, was discharged home, and here's their follow-up CT scan. You can see on the left upper panel the transgastric drainage with no residual collection, and the right lower panel with the transduodenal approach with no residual collection there either. And then we just performed EGD with stent removal and took out all the indwelling stents, including the transpapillary stent that had previously been placed. Well, what about endoscopic step-up therapy? This is something we recommend in the AGA guideline. And the step-up approach was initially a term applied to percutaneous drainage. So the step-up approach was percutaneous drainage, and if the patient did not improve adequately, the next step was retroperitoneal necrosectomy via the percutaneous drains tracts. And then if that did not adequately resolve the problem, then open necrosectomy was performed. However, recently an endoscopic step-up approach has been used and reported with good results compared to the surgical step-up approach with percutaneous drainage, with EUS-guided placement of 2 7 French stents and a nasal irrigation catheter, followed by direct necrosectomy as needed. And in this particular study, when compared to surgical step-up, the endoscopic step-up approach significantly reduced pancreatic fistula and the length of hospital stay. It was non-inferior to the other approach. Direct necrosectomy can be performed directly through the luminal opposing metal stents. Again, we believe that we should delay and wait on direct endoscopic necrosectomy for patients who fail initial drainage with luminal opposing metal stents or other transmural approaches with or without irrigation. Whenever we think about direct necrosectomy, we think about the risks, which include bleeding, perforation, bleeding within the cavity, which can be very difficult to treat, perforation of the cavity, air embolization, which has been minimized with the use of carbon dioxide insufflation. The costs, these are really time commitment procedures, and the small risk of stent dislodgement, with the benefits being, of course, higher successful resolution, perhaps earlier resolution, and then again, the costs that could be associated with a decrease in hospitalization. But again, from our guideline approach, we recommend delaying direct necrosectomy for patients who do not respond adequately to endoscopic therapy. Here's an image of direct endoscopic necrosectomy using a forward viewing endoscope through a luminal opposing metal stent. grasping necrotic tissue. There are a variety of approaches to perform direct necrosectomy. And here is that same patient with the necrotic debris having been removed. So on our AGA guideline algorithm, we have a patient with walled-off pancreatic necrosis, which is either infected or patients who have severe sterile symptoms and sterile necrosis. If there's a central component of sufficient size and accessible transmurally, we recommend EUS-guided placement of large bore luminal expandable metal stent for drainage. If there's a large pericolic gutter extension, we recommend aggressive percutaneous drainage concomitantly with the EUS-guided drainage, although this can be open for debate. If there's a large amount of solid debris and the patient is not responding to LAMS alone, we recommend direct necrosectomy if they don't have a percutaneous drain that you can irrigate through. If there's not, we remove the LAMS after resolution or perform, again, DEN, direct necrosectomy for failure of LAMS placement. So in conclusion, the literature is fairly supportive that endotherapy for walled-off necrosis is effective. There are a variety of endoscopic methods available. As I mentioned, the approaches taken for any individual patient, and certainly even the endoscopic approaches, are often center dependent based on, again, availability and expertise. We recommend large diameter self-expandable metal stents, particular LAMS, which we believe offer benefit over plastic stents, although again, it'll be, we'll wait to hear from Dr. Varadarajulu. And for patients with central walled-off necrosis, a large diameter SIMS is recommended as a first approach with direct necrosectomy as needed. Thank you very much. I look forward to discussion.
Thanks a lot, Todd. This is very, very useful. I think very comprehensive and easy to understand. And I think it's also very easy to implement guidelines from AGA. Okay, so I think I just want to remind, before I hand over to Ken to introduce Shyam, I just like to remind the participants that if you have any questions, I think please write it in the Q&A so that we can actually ask the speakers during the discussion session and all those questions. I've already seen about 2 or 3 questions. So I think we will leave the Q&A to the discussion after Shyam's talk, because the two are related. So it's easier for us to just answer all the questions by the 2 speakers. So can I hand over to Ken to introduce Shyam?
Yeah. So good morning, Shyam. Are you safe from the COVID-19? It's my pleasure to introduce you. He's very famous, Professor Shyam Varadarajulu. Today he will give us a lecture on the metal or plastic stent for pancreatic fluid collections. Shyam, are you ready?
I'm ready. Thank you. Thank you so much, Ken, for the kind introduction, and to Lawrence and Anthony for this opportunity. I've been with the AEG for a very, very long time. So I don't know about my protection from COVID, but you all realize that we need to be protected from President Trump. That's for sure. So my topic is metal or plastic stents for treatment of pancreatic fluid collections. These are my disclosures. I'm a consultant for Boston Scientific, Olympus, and Medtronic. So we know there are 2 types of collections. One is pseudocyst and the other is walled-off necrosis. It's going to be a quick lecture because I wanted to keep things very focused. So if we are looking at metal stents, there's only one metal stent.
Your slide has not been shared yet. Can you share?
Oh, mic is not turned yet. I'm so sorry.
Yes, please share the slide.
Okay, hold on 1 second. I'm pretty not very good with it's turned on at my end, Lawrence. Can you hear me now?
Yeah, I can hear you. Your slide, I think you need to go to the share slide. It's in green color. Just go to there.
Yeah, I see that. I did that. And then, can you see this?
Not yet.
Not yet.
Not yet. This is why I don't do anything concerned with the technology without G in my eyes.
Oh, it's coming.
There.
Sign of AG.
Just enlarge it a bit.
Okay, I'm going to do it. This is good?
Perfect.
Yeah, perfect.
Okay. So there are two types of collections, as we all know. One is a pseudocyst and another is walled-off necrosis. So this is going to be a very focused talk. I thought I will just address a key question that was asked of me by Anthony. So if you look at metal stents, there's only one type of a metal stent that we discuss these days for fluid collection drainage, and that is a lumen-opposing metal stent, or we use the plastic stent. We also know that there are no studies that have evaluated the role of LAMs exclusively for pseudocyst drainage, at least in a randomized fashion. All the fluid collections have been heterogeneous, including pseudocyst and walled-off necrosis. And I don't think I've reviewed a single literature talking exclusively on LAMs for pseudocyst drainages. So that data is lacking. But at least we know indirectly that this is a study of 122 patients about when you look at an uncomplicated pseudocyst, in a single intervention, irrespective of the size, location, size of the stent, number of stents, whether you place a concomitant pancreatic duct stent or not, and the morphology of the collection, you get a close to 98% success rate on a single intervention. And on only in a small subgroup of patients will you require more than 2 interventions. So for uncomplicated pseudocysts, the overall treatment success rate is about 98.3%. And this data is pretty telling. And I don't think we have such data for lumen-opposing metal stents. And this is an old meta-analysis from my group. And there have been subsequent studies that pretty much tell us the same thing. There might be a marginal efficacy for metal stents for walled-off necrosis, but when you come to pseudocysts, you can see that there is a significant overlap in the confidence intervals between metal and plastic stents, telling they both seem to be working identically well for management of pancreatic pseudocysts, and there is no difference. However, I think without much evidence, this is a situation where I think plastic stents score over metal stents for pseudocysts. So this is a patient that I treated 2 days back. He came with a fluid collection in the pancreas and abdominal pain. This is an unstent pull-through maneuver. You can look at the common bile duct, and the pancreatic duct is coursing right below the bile duct. And as you slowly retract the scope from the second portion, you see a stone occluding the main pancreatic duct. And this patient had intermittent pain. She's a non-alcoholic and not a smoker either. And then you gradually pull the scope back, and then you see a fluid collection right below that. This is an anechoic collection. There's very minimal debris, and that's a pseudocyst. And when you do a transpapillary pancreatogram, and then you inject contrast, you can see that the duct is completely blocked off somewhere at the genu region of the pancreas, and the stone just buckles the wire back, telling us that this is a disconnected duct, or an occluded duct is what I would say. So in these patients, I think we need to place an indwelling prosthesis if you can't fix the transpapillary problem, i.e. we have to either do a Pusto procedure, or we have to perform a laser lithotripsy, break the stone and leave a stent across to relieve that problem. Otherwise, this is going to be a recurrent issue. So in these patients, I think plastic stents are more ideal. So this is my summary slide for pseudocysts. I think for LAMs, it's a one-step technique. It's less costly, it's more costly, but the problem is we can't leave it in situ indefinitely. And whether it is walled-up necrosis or pseudocysts, we can use them equally well. Plastic stents, on the other hand, is a multi-step technique. We have to have a little bit of background experience in biliary interventions or ERCP to perform the procedure proficiently. It's less costly, but given the high PFC recurrence rate, one advantage of a plastic stent is you can leave the stent in situ in patients with obstructive ducts, and you can forget about it, so that there's the rate of recurrence will be much more minimal. And the clinical outcomes are all equivalent to LAMs. So with that statement on pseudocysts, I will move on to walled-off necrosis. Walled-off necrosis is a little complicated. I think the morphology, to some extent, dictates what we do with the drainage. If you see a collection like this, about a 25 centimeter collection, a unilocular LAMs should, for the most part, be able to help this patient. But we are seeing two discrete collections that do not communicate with each other and they are completely distant from one another, then you're going to require a multi-gated drainage. If both of them are symptomatic and both of them are large, you can place plastic or metal, but you will require a multi-gate technique to drain this collection. On the other hand, if you've got a collection like this, it's very close to the stomach, but you also see a large collection tracking down. There's a little bit of air in this collection. And in this particular case, you will require a dual modality treatment where you have to place a lumina-pushing stent, and we must place a percutaneous drain because once instrumented, this is going to be more infected and will require some sort of drainage. And finally, you've got these type of collections as well. You've got a central collection that is huge, and then you've got a peripherally enhancing pancreas at the tail region. This is a disconnected pancreatic duct syndrome, and I will share with you some videos on how we manage these patients. In fact, we prefer to place both a lumina-posing metal and a plastic stent in some of these collections. And the disconnected duct, I don't want to beat on this topic too much. Many of you may have seen these slides already. This is an entity that we just need to be aware of. This is a study of 331 patients where you can see that if you have a disconnected duct in conjunction with a necrotic collection, these patients will require more advanced interventions. You will require more re-interventions, and unfortunately, some of them will require more rescue surgery just because this is an aggressive disease compared to patients in whom the duct is preserved. And finally, this is a very recent study that we have shown, and the take-home message is very straightforward here. I think if you're placing a lumina-posing metal stent for drainage in patients with a disconnected duct, if you exchange a metal for a plastic stent in a timely manner, then I think the rate of recurrence is much less. On the other hand, if you do not replace the lamps with a plastic stent, then these collections recur. And this was the independent variable for disease recurrence in patients with fluid collections and a disconnected duct syndrome. So what we do in patients with a disconnected pancreatic duct syndrome is to modify the technique of drainage if the fluid collection is more than 10 centimeters. So what we do in these patients is we go do a good MRCP to learn the anatomy. And then if you see something like this, but the collection is pretty large, it's almost encompassing the total pancreas. There was a little bit of tail left on the coronal view. And this patient also has got a fluid collection that tracks down into the lower abdomen and the pelvis. So what we do is you go more proximally into the antrum or the duodenal region. You find a good spot for draining this collection, and you place a 20 millimeter lamps into the collection. So that is a perc drain already in place in this particular patient. This is the first lamps that is being deployed, and you can see a necrotic material that is being drained. And after we do this more proximally because this is the best part where you can go and do a transgastric necrosectomy. If you place your stent more proximally, it's going to be difficult to access the cavity. Then we go towards the tail region, and then you leave a plastic stent in the old conventional fashion. You just use a cystotome, you go inside, you coil your guide wire, you dilate the tract. You can see necrotic material coming out. We put on a 15 to 20 millimeter balloon on this, and then you deploy double pigtail plastic stents. And the reason we do that is we believe that in patients with a disconnected duct and a collection more than 10 centimeter, they require more advanced interventions than just a uni-tract drainage. And in 72 hours, you can see a fairly good response to treatment. And what we do in this case is on follow-up in about 3 to 4 weeks, you remove the lamps and you leave the plastic. In this way, the tract is secure. The plastic stent is going to secure the tract. The cavity is not collapsed. And when you go back, you just remove one stent and you leave the plastic to drain the tail region of the pancreas that is viable. What else is important in determining treatment outcomes? I think we still don't know the complete answer to the first question. When is transmural drainage alone sufficient for necrotic collection? And I think we know a lot of data on what LAMS does for these patients. If you look at indirect evidence, this is a study that came out of India that, it's a very small subset of patients, but they told us if your necrosis is less, you will require fewer sessions of drainage and maybe less necrosectomy. And as the necrotic debris progressively increases in quantity, then the need for necrosectomy and additional intervention progressively increases. We also have indirect evidence from all our studies, all the randomized trials that show that when you randomize patients to a endoscopic cohort or an alternative treatment group, only about 40 to 45% will require, 55% will require necrosectomy, and a third to 40% of patients can be managed with drainage alone. So we know from indirect evidence that a significant proportion of patients can be managed just with transmural drainage and will not require a necrosectomy. This is our own study that also reinforms something. This is indirect evidence where we compared plastic and metal stents, and you can see here there was absolutely no difference in our randomized trial of about 60 patients with metal and plastic stents for walled-off necrosis, and all these patients had collections more than 35 to 40% in quantity. But what we don't know in walled-off necrosis is there a subset of patients who will specifically benefit from plastic stents? Common sense tells us that maybe if the necrotic debris is less than 10%, less than 20%, maybe a cheap plastic stent will do the job. But unfortunately, we don't have data to prove a 90% or a 95% efficacy in this patient population. They are all retrospective studies which come with their inherent limitations. But when you place a lumen-opposing metal stent, in my limited experience, I think it's very important to place the stent in the lower half of the stomach, because this is the place where we need to place it so that we can access the tract much easier for performing an endoscopic necrosectomy. If we are not patient enough, and then if you go and place a stent in the proximal stomach, as we have done here, because we had limited option, because the collection was fairly small, then this is what happens. It's very hard even to access this collection for drainage, leave alone go into that area on the gastric cardia or the fundus to perform an endoscopic necrosectomy. It becomes very challenging. So choosing an access site is important. Again, we don't have data. We have only the Axios into the United States. But when we see necrosis more than 30%, we always put on a 20 millimeter lumen-opposing metal stent. And I try to keep them in the distal stomach as much as possible. If the PFC is more than 10 millimeter from the transducer, which generally happens with uncented collections, and we are hesitant to go through the transduodenal route, then if you're going from the antrum, once the collection collapses, this is when perforations can happen. As the cavity becomes smaller, it peels away from the GA lumen and you can have free air. So in these circumstances, I use a 15 millimeter length saddle to minimize the risk of perforation. And again, you know this data from before, from our early experience with the randomized trial, that when you leave the lumen-opposing metal stent for a longer period of time, beyond 3 to 4 weeks, we have got complications like bleeding, buried stent syndrome, and sometimes you can have a biliary stricture once the fluid collection resolves with the lumen-opposing stent compressing the common bile duct. So we generally recommend removal in 3 to 4 weeks, and if required, if there's a disconnected duct, to replace the lamps with a plastic stent. And what are the adverse events? I think this is another study that we recently completed, where we have shown that not all patients bleed. Again, the sample size is small. Again, this is subject to interpretation and limitations because this is from a prospective registry. But what we found is if your fluid collection is less than 7 centimeter, you've got a problem. And if you let the stent indwell for more than 4 weeks, the chances of hemorrhage is significantly more if you remove them in a timely fashion. If it's a very large collection with a lot of debris, I think leaving a lumen-opposing stent for a 6 or a 7 week period may be okay. But again, as I've told you earlier, sometimes bleeding happens even within a 2 week time frame. So this is our approach between plastic stents and metal stents for fluid collections. So if it is a pseudocyst, as you know, in the United States, we get paid for a majority of these patients. Cost is not an issue. What we do is a lumen-opposing stent is placed for every patient. The only time we place a plastic stent is if you've got, I wouldn't say a disconnected duct. It happens less with pseudocysts. If you've got an obstructed duct, multiple stones impacting, you can't access transpapillary drainage and you can't do any treatment. Then we just leave a plastic stent in these patients and just don't even worry about it. You do a CAT scan, patient is good, you let them indwell to minimize recurrence rates. If you've got a unilocular collection based on the imaging I had shown you earlier, then something like that, then we just place a lumen-opposing metal stent, maybe 20 millimeters or 15 millimeters based on the degree of necrosis. You got a multilocular collection or 2 collections. They do not communicate with each other. They're completely discrete, separated by an intervening parenchyma and so forth. Then we do the multi-gate drainage. We put 2 lumen-opposing stents, or depending on the cost, you can do what you want based on local factors. But this will require multi-gate drainage. Fortunately, not often, but it does happen. If you're looking at a disconnected duct and the collection is small, say for example, 6 to 10 centimeters, then I don't think a multi-gate is going to work, because as soon as you place a single stent, everything is going to drain off. In these patients, we will put in a 15 to 20 millimeter lamps, preferably a 20 millimeter lamps, and we bring the patient very compulsively within 3 weeks. We don't want that cavity to collapse. You go back, you remove the lamps, you flush, you irrigate, and then you leave your double pigtail plastic stent so that you maintain the track for draining the disconnected gland. If the collection is more than 10 centimeters, again, we have shown from our prior manuscript in the Annals of Surgery that these patients require more necrosectomy, more interventions. So in these patients, we go and do the multi-gate drainage, one using lumen-opposing metal and the other using plastic stents towards the tail of the pancreas. Once all your treatment is done, we remove the lumen-opposing metal stent and let the plastic stents stay in situ. And then they will involve forever, and we never remove these stents. And over a period of years, we always see that they just tend to migrate away, leaving hopefully a permanent fistula. And finally, if your fluid collection is extending to the lower flank and the abdomen, we do what we call the dual modality treatment that has been described well by Dick Kozarek and to some extent by Todd, where we go and leave a lumen-opposing metal stent, doesn't matter depending on the size and the ductal anatomy, a single or a multi-gate drainage, and then you leave your large bore, the percutaneous drainage catheter to drain the flank collections. This is our protocol. If you don't respond well to treatment, which we define as persistence of SIRS and collection on follow-up imaging within a 72-hour period, then those patients with a solid debris will undergo necrosectomy. With a predominant liquid debris, we do multi-gate drainage. Whether this works or not, you can ask us, but I think we will have the data very well. One thing that we do is we collect data very obsessively on all of our patients. So we have collected this data in 425 patients doing a step-up approach. We have collected about probably 400 variables on every patient. Several may be lost to follow, but for the most part, we have at least a 6-month data, and in many patients up to 5 years. And this will be something that we are hoping to get published to tell whether this algorithm of metal or plastic stent that we propose works or not. But one thing is sure, just sticking a stent, a metal stent or a plastic stent into your collection and telling is magically going to work is all gone. I think we need to take into consideration multiple factors based on morphology, the ductal status, the status of the residual gland, the way it tracks to the lower abdomen, and then you tailor your strategy to drainage. And that drainage strategy should facilitate a way for necrosectomy. And it is not all going to be lumen-opposing metal stents, although this is 2020. As I've shown you earlier, there appears to be a definite role for plastic stents in pseudocysts with obstructed ducts. In patients with disconnected duct syndrome, I think the plastic stents do have a small role if you do the dual modality, if you do the dual track treatment. And finally, I think exchanging lamps for plastic stents still is relevant if you have a disconnected duct. So I think there's a role, although small, for plastic stents, but for successful management, we have to adapt both the stents for good clinical outcomes. Thank you.
Thank you, Shyam. It's a very nice lectures. So from the audience, we have several questions. What length and the size of double pigtail stent do you insert through the lamps, 7 or 10?
No, I know, Ken, there's a lot of question about putting in a plastic stent through the lumen-opposing stent. In my own experience, especially in the proximal stomach, when we have done that before, there was a buried, the stents got buried under the mucosa due to poor follow-up, and both stents were hung up. And the plastic stent being very long created more problems. So we never do it. I think it just increases the procedural duration. It subverts the process. We might as well dilate to 20 millimeter and put a couple of plastic stents. The whole question of procedural elegance with lamps is a short procedural duration. So no, I don't go and put a plastic stent through the lumen-opposing metal stent. I don't do that.
So I take the opposite approach completely. I put a 10 French double pigtail stent in all my luminal opposing metal stents, and it doesn't really increase the procedure time much because I preload a wire in the luminal opposing metal stent, burn in, put the wire in, deploy the stent, quickly exchange the device off the wire, load a 10 French pigtail stent with a 10 French introducer, not just the pusher tube, but an introducer, and it goes right through. And I do that I've not had any bleeding, even if I leave the stents in longer than 3 or 4 weeks with that approach. And I think it actually does the opposite. It doesn't provide buried lambs, and you have an access to get back in if you need to. It also, I think, prevents impaction of necrotic material in the lumen of the stent. But again, that's just two different ways of doing it. But I use 10. So for a 20 millimeter stent, I put a 10 French 4 centimeter stent, because if you put a 7 French stent in, it's going to fall out. I don't use 10 millimeter stents for much, but if I ever do, I use a 7 French stent. So I use 10s for the 15 and the 20 millimeter, and a 7 for the 10s.
Okay, so maybe I can actually go to the audience questions. I think there are a number of questions relating to the indication for doing necrosectomy. Okay, so they're asking, apart from clinical symptoms, meaning that the patient is not improving, how do you decide when to do the necrosectomy? Is it based upon imaging or some laboratory testing and so forth?
Well, it's a combination of things. Often the patients that need necrosectomy, again, are patients who had some clinical improvement but not enough or adequate. So the most typical symptom or indication is they have, let's say they have sterile necrosis, you put the stent in and you don't do anything, and then they get readmitted with infection because the procedure contaminates the necrosis. Then obviously you get a CT scan, and if there's a large amount of residual necrotic debris and they've presented with infection, then I think you're obligated to go in, especially if the CT hasn't markedly improved, to do necrosectomy. On the other hand, if you have somebody who's very, very sick and been in the hospital a long time, and you do the procedure and they're just not clinically getting better, and again, you re-image them and they've had some improvement but not a lot, or they have ongoing infection, I think then you need to go back and do the necrosectomy. Often you'll see there's a large volume of residual necrotic debris on the CT scan, and that the collection hasn't substantially decreased in size from the prior scan.
So, you know, unfortunately with PFC management, there's no good treatment strategy. I don't think we have done a good job of doing a standardized approach or an unstandardized approach on re-interventions. All that we do is to compare a metal stent, a plastic stent, a few bunch of techniques, write a paper and we move on. And that is why this is not, at least in our practice, everybody will get religiously a CT scan at exactly after 72 hours. Everybody will get it, unless you're an outpatient with a pseudocyst. And then you look at the CT scan, and then we look at we have a formula. Again, you can criticize us whether it is right or wrong. We look for a decrease in size of the collection by more than a third, and then we look for persisting SIRS. If you don't have SIRS, and the collection is say better by 35 to 40%, we don't do anything. We tend to follow these patients, and then we discharge them, and if they do good, we get a scan another 4 to 6 weeks. If they come back, we will re-image and then we treat them. So we have some data to say that, for at least for inpatients, 72 hours is a good window of our treatment outcome to assess a treatment outcome.
Oh, Marco, what is the experience from the Dutch pancreatitis group? How do you select patients for necrosectomy? Do you do necrosectomy for all patients with a lot of solid component, or are there some that do not need them?
No, some don't need it, in our opinion. We do it only when clinically indicated. So that means very often you have these patients. So it depends a little bit. Patients you have trained, like Shyam was referring to, who do initially very well, and then all of a sudden get being referred back to hospital because they don't feel well. Some are very sick, are septic. Some are, they're just not well and not doing clinically well. And there's clearly a change as compared to the previous weeks after they were trained. And in my opinion, you should not wait too long. We have a very low threshold then, once a patient has been drained and is not doing well, to go for necrosectomy, because in our experience, that's always the reason why the patient is not doing well.
So I think maybe I will ask the questions from the audience about how long do you keep the stents in? I know this has been asked many times. When do you decide based upon the imaging, or do you image the after you leave the stents in. Maybe I think Shyam and Todd, what are your thoughts?
So for us, as I've told you, the patient is in the hospital. Some of them are there for months, and you repeat a scan, and you got this 14 centimeter collection that's hardly budging. It's big. There's a lot of air. There's a lot of debris. They are sick. Then there's no 3-4 week time frame. I mean, you can leave it safely because they're in the hospital and so forth. But generally, if you discharge the patient early, the 4 week time frame is a good time frame for repeat imaging. You repeat the image at 4 weeks. The cavity is collapsing. It's only 2 to 3 centimeters. But I think it's very reasonable to go pull the stent out. If required, you swap it for a plastic stent. But you image it 4 weeks, and if the patient is still having a lot of collection and so on, then I think you can be pragmatic and leave it for a longer duration. No set answer, Lawrence, but I think, yeah, for a collection that is becoming smaller, less than 3-4 centimeters, the patient is doing great. I think the 4 week time frame is a good time frame with the LAMS, because prospectively collected data, despite what people have been telling, is bleeding is a problem. That is one. And second is, people always say, oh, well, there's no bleeding in my experience. Let's face it. In colon cancer, when you do screening, we are not looking for 1 million colon cancers to justify colonoscopy. We are looking for those 3 to 5%, 3 in 100 patients who may have colon cancer. So this is the logic that I use for my patients.
What about Todd?
I agree. I agree with exactly with what Shyam said. Is 100%.
Okay.
Yeah, that is unbelievable. You have agreed with somebody for something. That is, what does the world come to?
I know.
COVID.
Okay. Another question. This is just a practical kind of thing. Do you all intubate patients routinely before you place the lamp, in case the patient aspirates?
So I generally will leave it to our anesthesiologist, but in general, yes, we do intubate patients, just like you said, for fear of potential aspiration during the procedure. But you know, I would say that if you have, you know, you could also argue that with a tremendous amount of solid debris, you may not actually get a lot of fluid, so it might be more important actually with a pseudocyst to intubate the patients. But in general, we do general anesthesia, yeah, and intubate.
Agree.
Okay. Just a question. I think before we move on, I think Shyam, you mentioned about disconnected pancreatic duct. How do you confirm that? So
yes, there are multiple ways of looking at it. If you get a good MRI before the procedure, good MRI, and there's a lot of tail preservation, you'll be able to see something. That's one. The second thing is a CAT scan will also, it's a very classic image. You got a middle pancreas, a fluid collection that is necrotic, and then you got a body, your tail that opacifies, that looks pretty good. That's very, very good actually. Most times it's not going to reconnect. And then thirdly, if you are lucky in a chronic collection, you know, there's nothing called a chronic necrotic collection, but a collection that's been there for a while, you will have a dilated duct in the tail. That's a telltale sign. And the fourth thing is probably the most difficult, which is by EUS when you drain the collection. It's very important to do a pull through. And then once you see a collection in the neck region, and then you gradually pull the scope, what happens is the collection is going to kick the scope over. Then you go back, you trace a celiac artery, and then you come back into the tail of the pancreas. And again, once again, if you see a viable pancreatic tail region, more than 3 or 4 centimeters, between these four, one morphological feature will light up in about 85 to 90% of patients. Sometimes nothing is going to help. Only when you go and do a repeat imaging at 4 weeks, when the collection becomes small, you will identify a disconnected duct. But trying to find this intra-procedurally or pre-procedurally does impact treatment outcomes for us.
Okay, good. Okay, I think there are quite a number of questions. I'm not sure whether we can answer now, because the next speaker will also be dealing with necrosectomy. Yeah, I think there are quite a number of questions on the necrosectomy as well. If we, maybe I can just quickly go through one last question before we move on to the next speaker. The question is it possible to place 2 plastic stents as the I think Shyam mentioned about multi-gate. Instead of putting one lamp and one plastic, is it possible to just put 2 plastic stents?
Of course, I think if I were to be practicing in India and Madras, of course I'll do plastic stents. I don't think it's a deal. The thing that we have to be cognizant of is when you go through the first tract, and usually in the more proximal stomach, it is very important to curb our enthusiasm. As soon as you dilate it to 15, 20, things start pouring out. And then once you coil your guide wire and deploy your stents and the cavity completely collapses, then you can just forget it. It's not going to happen. So it's important to just dilate, leave the stent, don't start aspirating, but immediately go to the more distal collection towards the tail, and then drain that collection. And after you do that, you can put your cannula into the collection, and then you can aggressively irrigate. So that is the only thing that I would encourage people, not to be very aggressive in decompressing the cyst after the first tract has been placed. But absolutely, multi-gate plastic, sure, works great.
Okay, thanks, Shyam. Okay, I think it's 9 o'clock now. Ken, do you have anything else to add before we?
No, yeah, of course, our schedule is limited time. We have limited time, so please go on the next sessions.
Okay, so thanks a lot, Shyam and Todd, for the excellent, I think, talk. And more importantly, I think the very useful discussion and heated discussion. It's not a debate, but this is just a discussion. Okay, I'm not sure, Anthony, is the next group of moderators here ready?
I don't think so.
Oh, okay.
I think you have to be moderators to continue to be moderators. Maybe I can help also.
Okay. So maybe I think we will, okay, I think we were going to move on to the next, I think our next speaker, who is going to actually share with us something relating to the first talk by Shyam on disconnected pancreatic duct after drainage of pancreatic fluid collection. And the speaker is going to be Sundeep. I think he needs no introduction. He comes from the very famous Asian Institute of Gastroenterology in Hyderabad. So I think, and he is an expert, obviously, in EUS and then ERCP and so forth. Sundeep, would you like to share your slides soon?
Do you see my slides?
Not yet. You're using Mac or PC?
Are you able to see now?
Not yet. Are you using the Mac or PC?
I'm using Mac.
Oh, okay. Same problem as Shyam.
Okay. Just a minute.
You take your time.
Okay.
Okay, now, yeah, we see that. Good.
So good evening, everybody. Greetings from India. And I would be speaking on disconnected pancreatic duct, how to manage it after draining pancreatic fluid collection. So the agenda for this talk is what is disconnected pancreatic duct. I just want to bring it to perspective, and it has to be a uniform definition before we go forward. What I believe is the clinical relevance of it, and how can we manage it endoscopically. We all know that acute necrotizing pancreatitis, if it is causing damage to the main pancreatic duct, leads to disconnected pancreatic duct. So pancreatic parenchymal necrosis, when it involves the main duct, causes the epithelial cell damage of the duct, causes loss of integrity. And this disruption over a period of time, when it causes scarring of the both ends of the disrupted duct, will cause disconnected pancreatic duct. It is most often associated with acute necrotic collection, which eventually evolve into walled-off necrosis. And if we see the definition proper, which was given by Dick Kuzarek, it is characterized by complete disruption or disconnection, as you see in this MRCP on the left panel, of the main pancreatic duct, resulting in variable portion of the upstream pancreas getting isolated from the downstream pancreatic duct. It's very important. So when we define pancreas or define pancreatic anatomy, we have to use the term downstream, which is towards the head, and upstream, which is towards the tail, not proximal and distal, because distal CVD is near the proximal pancreas and that causes confusion. You can also make out, as Shyam said in his talk, on CT scan that the disconnected duct is visible, the tail area especially, and some duct also can be seen. All stents are quite efficient in draining pancreatic fluid collections. I don't want to go into that. Shyam has adequately covered on it. But what should we do for pancreatic disconnected duct? Do we need to change our strategy? For collections, endoscopic drainage is safe and effective. And the initial management of all these collections, our focus always is on drainage, be it plastic, metal, 1, 2, single gateway, multiple gateway. But less emphasis is placed on PD disruptions, which is the root cause of all these collections to form. And how do we tackle this problem later on after the collection goes away? That's where the debate lies. So when do these disruptions, that is a leaking duct, becomes actually scarred and disconnected by a scarred tissue? And what are the long-term implications or sequelae of this disconnected duct? If you look at this cartoon, this is the collection. The downstream duct is now disconnected from the upstream duct, which has a necrosis in between. We drain it from the stomach by plastic or metal or both. And once that resolves, this area then heals up with scarring. You lose this amount of pancreatic tissue. It all depends on the severity of index episode of acute necrotizing pancreatitis. More severe the pancreatitis, more damage is likely to happen. More gap will be there in between these two places. How much pancreas is viable upstream to the disconnection also makes a difference, because whenever we eat food or we do our physiological activities, this pancreas continues to have its neurohormonal connection intact. It will keep leaking juice or forming juice, and if it's not able to come out, then it will cause pain, eventually can rupture, or if there is plastic stent inside, it will keep draining through that plastic stent, which works like a wick, into the gastric cavity. Or if you have an external drainage, for example, you placed a percutaneous drainage, that will also keep leaking. So you can have an external pancreatic fistula, the internal stents can help drain inside, or if you have removed everything, then this can cause a problem in future. How severe is the problem? What is to be done for all this is what I will take touch in this talk. Before I go further, I want to just present this slide, a unifying concept of pancreatic duct anatomy, both predicts and determines the major complications after resulting from pancreatitis. This is a more than 10-year-old paper, but defines how the cyst or the collection is in relation to the duct. It may be disconnected, it may not be connected at all, or there can be, so the type 1, 2, 3, and 4, there are various types. In 1, there is no connection with the duct, but in type B, there is a connection with the duct. In type 2, the downstream pancreas and upstream pancreas have a stricture formation after the resolution of the collection. In type 3, the anatomy remains intact, but you see there is a disconnection now. There is a fibrosis here, and there can be variable length of this disconnection. And type 4 is in context of chronic pancreatitis. So in this publication of more than 563 patients collected over 20 years, the author said that after the patient has a percutaneous drainage, this publication I'm mentioning because this leads to a knowledge of how we drain internally also. If we drain externally by a percutaneous drainage, PD means percutaneous drainage, not pancreatic duct. So in type 1, the chance of persistent fistula is very less. But as the stricture, it is 50% will have a persistent fistula, but in disconnected duct, there will be 100% fistula. It's very intuitive and logical that upstream duct will keep draining through that catheter which has been placed in the cavity. Also, failure of the percutaneous drainage is also varies with the type of where the narrowing lies or the duct is normal. So why DPD is important? One, it can lead to recurrence of pancreatic fluid collection, as you can see in this one. Or if there is a patient who has been treated with an external pancreatic catheter or at surgery with an external tube, often these tubes are a lingering problem for many, many months. And they suffer from this external tube hanging, which is draining 50 to 100 to 200 cc of pure pancreatic juice. How to get this tube off is because of disconnected duct, and how we can deal it. So management of external pancreatic fistula is often conservative, especially in a post-surgical scenario. If there's a partial disruption, either it heals on its own or you do an ERCP and bridge that leak. But if it is disconnected, means now the entire duct is not communicating with upstream and downstream are two different islands of pancreas. This will lead to external fistula, and this will require more than conventional therapy, sometimes called as hybrid therapy, or even surgery where you can do a drainage procedure or a resection procedure. So what are the issues with disconnected pancreatic duct? When to diagnose it? Timing according to the course of disease. Does it happen right in the beginning of acute necrotizing pancreatitis? Does it happen somewhere when the wall is mature and is about to get drained? Or does it really happen after you have drained and the fluid collection is resolved? What is the ideal modality of choice to confirm the diagnosis, and what is the treatment strategy if it's required? So DPT diagnosis, Shyam was saying it's easy to diagnose, but I feel sometimes it's very challenging in a pre-drainage scenario. The challenge is because the cyst, if it's large and has necrosis, the disconnection, the imaging of the fluid collection will not allow the duct imaging very easily. And often it overlaps the duct. In spite of rotational images, we may not be able to pinpoint where the leak is happening or the disconnection has occurred. What about the time of drainage? Shyam has shown in some of his publications that you can diagnose at the EUS drainage. But even in such a scenario, if the collection is very large or has large amount of necrosis, it's not very easy to see. Especially upstream duct may not be seen very well in a large vault of necrosis. Also, a compression by these large collections onto the pancreatic duct may be misinterpreted as a disconnected duct, which may not be there actually. So most often the diagnosis is made post-drainage after the resolution of pancreatic fluid collection, and ideally done with a dynamic imaging, most often of an MRCP, and if a facility of a secret in MRCP is available, that's the best, or in combination with an ERCP. The aim of this is to prevent progression of disruption now to disconnection. So if we can salvage this process, we can probably save that amount of pancreas rather than losing it. So which imaging is best? There's a publication from the Dutch group. I'm sure Marco will touch upon it. And they have seen many publications using various modalities, and most common modality was MRCP. They concluded that secret and MRCP, if available, or just an MRCP is a recommended first diagnostic modality. Let me show a video of a pseudocyst with a disconnected duct. This is a pure pseudocyst, no debris inside. And as you tilt towards the tail, you see a thin duct going up, which is a little prominent. So that's the disconnected duct, likely because of this pseudocyst. So how do we treat it? The conventional wisdom has been told that if you leave the plastic stent inside, as Shyam was alluding to, the chance of reoccurrence of these fluid collections is much less. And this was shown in one of the publications from Jacques Davier's group in 2007, where in one arm, after drainage, they left the stent in situ. In other arm, they removed the stent. All the numbers are very small, but the reoccurrence was much more common in the group which had the stent removed. The follow-up period was about 14 months in mean. This is Shyam's publication, Importance of DPDS in Recurrence of Pancreatic Fluid Collection, initially drained with lamps. I would touch upon this. This was the flow chart given in his paper, and it says that if you have a plastic stent placed out at the exchange, then the risk is much lesser. This is quite intuitive. But how long do we leave these plastic stents? There are obviously challenges also with plastic stents. They're not fully safe. Risk of spontaneous migration, including causing a luminal obstruction in small bowel and colon, has been reported in small numbers. and the disconnection continues to be remaining there. It's only draining off part of the juice which is being secreted from the upstream pancreas. Also, the unanswered question remains is how long to keep these stents, indefinitely, lifelong. What happens to this DPTS? Does the pancreas get atrophied over a period of time? And other issues are linked with DPT. So again, Dutch Pancreatitis, which very systematically analyzes many of their own publications and other publications, looked at this, the treatment of disrupted and disconnected duct in necrotizing pancreatitis, a systematic review and meta-analysis. They used many publications with various treatment options done in all of them. And the treatment of choice was actually inconclusive. So nobody knows the real answer. And that's where we all need to get together to probably find an answer that how to manage this problem. They also concluded by saying that there's lack of systematic diagnostic workup, lack of risk analysis to predict treatment outcome, and absence of studies reporting on conservative treatment. So keeping this in mind, we had our own publication from AEG in gut this year with Jahangir as a first author, impact of disconnected pancreatic duct on the reoccurrence of pancreatic fluid collections. And another new dimension is new onset diabetes. Do we have an answer? So this was our study design. All the patients of walled up pancreatic necrosis underwent drainage with Nagy stent. They had the stent removal at about 4 weeks. Before that, they had an MRCP between 4 to 8 weeks at the time, just before the prior to the removal. The aim of this MRCP was to get the ductal anatomy. If there was a cutoff or if there was a normal PD, then these stents were just removed. But if there was a pancreatic leak suspected at the time of the stent removal, we did an ERCP. And if there was a leak at that time, then we bridged that leak using a transpapillary plastic stent. Obviously, metal stents were removed in all patients. And then these patients were followed up regularly at 3 monthly follow-up. And we have data for 2 years to more than 5 years in this large cohort. And this was the number of patients that was included in this study, 256. You see, majority of them, 74% of them have, that is 3 out of 4 will have disconnected pancreatic duct, proven objectively, either by MRCP or combined ERCP. About 14% will have a normal pancreatic duct, 7% had a pancreatic leak, 4% had a pancreatic stricture, which means there was a narrow duct, but the contrast could go beyond into the upstream duct. And there were some patients who were not diagnosed early, had pancreatic calcification. That means they were upfront chronic pancreatitis. What does the imaging tell us? So MRCP told us that majority had disconnected duct, but when it did ERCP in the same patient, it was found in lesser number of patients. So MRCP actually overestimates the plain MRCP, not the secretin MRCP. We don't have facility of secretin MRCP with us, but plain MRCP overestimates disconnected duct and PD strictures. So we should do an ERCP and try to salvage those small percentage of patients which may actually benefit by a transpapillary stenting. It also underestimates a pancreatic leak. And these were some of the images that was in this paper: normal duct in the head and the proximal downstream body. Mid part of the pancreas is totally gone, and upstream duct is dilated because it's not able to drain out. This is an Nagy stent here. We do an ERCP just before removal. The disconnection here is in the mid body. Another patient has a disconnection in the distal body, that is upstream body towards the body tail junction area. This was the flow chart. So 274 patients had drainage with metal stent. Anatomy could be established in 256. But look at this carefully. Only 13.2%, 34 out of 256 patients had a reoccurrence of collection. So reoccurrence of collection is not a major problem. Also, you look at carefully, out of these 34, 7 were totally asymptomatic. They were small collections and not causing any problems. And we conventionally know that any collection which is not causing symptoms need not be drained. But those which are symptomatic, if we kept following for some more time till they went for interventions, some of them spontaneously resolved. So in net, only 6.6% of those who had a reoccurrence of collection, that means half of these 34, 17 had re-intervention, and majority could be drained by EUS. Only one required surgery. So the problem of, or the frequency of DPDS is very common, but DPDS does not cause major problem. Moving further, we also found something very interesting, that some of these patients develop diabetes. We know that acute pancreatitis, acute necrotizing pancreatitis can cause diabetes at that time or later, but we all found that those patients who had DPD had a higher frequency of diabetes compared to those who did not have DPD. And this group had diabetes probably because of loss of pancreatic parenchyma, which was secreting insulin from the beta cells. One more interesting thing which I would like you to see on the right panel in this graph, in this Kaplan-Meier curve, that those patients who had disconnection towards the head side, which is also called as proximal part, towards the head side, had a higher chance of developing diabetes early in the course of disease. Those who had distal disconnection occurred later, and those who had normal pancreas duct had even much later. So this was important conclusions from this study. So let me just sum it up. So DPD is frequent. 3 out of 4 patients who have necrosis, walled-off necrosis undergoing drainage will have DPDS at that point of evaluation. Presence of DPD is a risk factor for recurrence of collection, but it's not a very important factor. So overall symptomatic reoccurrence occurs only in 10% patients. So 90% of the patients who have DPDS will not have any problem. Out of those 10%, about 6% will require some intervention. And DPDS is a significant risk factor for new onset diabetes mellitus. Higher the disconnection, that means more towards the head, higher the chance of developing diabetes. So what are the implications of this study? Risk of recurrent PFC is negligible in the absence of DPD. So if a duct is normal, don't bother about patient. You can reassure yourself and the patient that the risk of reoccurrence of collection is much lesser. But if DPD is there, majority of the recurrent PFCs will subside on their own or will be asymptomatic and then can be managed conservatively. So our group now challenges the accepted practice of keeping this double pigtail plastic stents indefinitely. In fact, we do not insist on it now, and we are prospective looking in a randomized control trial in placing plastic stent at the time of drainage in one arm, at the time of removal, and the other arm we're not putting any stent. And even if suppose the patient develops a collection, we can always, which happens in a very small number, we can always drain these symptomatic pancreatic fluid collection, which happens in a minority of patients later on by EUS. Let's come to specific treatment of disconnected duct. When do we really treat them? If they have recurrent pain, because the duct is obstructed, secreting juice and causing pain and recurrent pancreatitis, or recurrent collection or persistent pancreatic fistula. Let me show you some cases over here. This is a patient who had a disconnected duct on MRCP. We tried ERCP at the time of removal of stent, and you see the duct is disconnected in the head. Very high chance of diabetes developing this patient. Nothing is going in, but we could see that the duct was, the disconnection segment was very small. We kept forcing in, and we injected a little bit of contrast in a small collection. So now we know that we are very close to the duct, which has a, so we took a EUS, filled the duct, got into the same collection, and then drained it through the stomach. Another case, this patient also had drainage in the recent past. You see, it looks like a pancreatic stricture in the head. This is not chronic pancreatitis. This has occurred after a drainage of acute necrotizing pancreatitis leading to WOPN. You can make out the disconnection in the head. We do EUS, no contrast goes here towards the head. We drain it from towards the genu side and pass the wire to the tail and then place a plastic stent across. Mind you, these patients are symptomatic patients. They have disconnected duct, but the intervention was done because they had symptoms of pain. Another case, a recent case, he has a disconnected duct. You can see very nicely. The PD is very nice in head and up to the mid body. Then we see dilated upstream PD. This patient came with pain again. We thought we will do an EUS guided drainage of the pancreatic duct. The moment we filled contrast, you see a streak of contrast has gone towards the head side. Now you see it better. So we were very happy. Now this patient actually has a stricture which was misdiagnosed or overdiagnosed as disconnected duct and MRCP, and that's what we said earlier. So the moment we saw this, we thought, okay, we can now do transpapillary intervention in this case. Although we tried to pass the wire, I thought we can use that wire as a mechanism, but that didn't happen. Nevertheless, now we are sure of the anatomy. We went transpapillary and placed a transpapillary pancreatic stent across the stricture. So now we can salvage the tail, prevent his diabetes, and prevent his future recurrent pain abdomen. Last case of this group, I would say, this patient had a recent drainage with Nagy stent. We always place a plastic stent, 7 French, 5 centimeters through the stent. Now, when he came for removal, you can see the duct is dilated up. You can also see the stent here inside. And the MRCP looks at the duct is okay till the genu body junction. And there is a long gap, and then there's duct which is dilated above. So at the time of removal, we normally do pancreatogram. And that's what we did in this patient. The plastic stent in this case had migrated out, so metal stent is inside. So we injected contrast gently. The duct is normal up to the proximal or mid body, I would say, but some contrast leaked up. And that's a very good thing to see. Mind you, MRCP showed it was disconnected, but ERCP showed it's just a stricture. And then we passed a guide wire. That means the wire went into the stent, which means it's still leaking. And then we manipulated the wire into the duct upstream and towards the tail and placed the stent. So we could now bridge the leak and the stricture with this stent. So the aim is to salvage as much pancreas as possible. There are other methods to tackle these external fistulas and DPDS. This is again from Dick Kuzarik's unit. Shayan Irani is the paper author, who they pass a stiff guide wire through a percutaneous tube, then use a transjugular liver biopsy needle, come very close to the stomach, pass the EOS scope, and through this needle they puncture the stomach, pass the guide wire, and then this guide wire is caught, and then they place a plastic stent on top. If you are able to pass a guide wire through the duct into the head across the papilla, then you can do a roundover procedures. Like in this case, we did recently, where the guide wire actually was telling us that this is the path to follow, and then we did transpapillary drainage. So there are many ways to tackle this problem in patients who are symptomatic before they have developed collections. If they form a collection, you can drain it plastic stents and leave it off. But before that, they will give you messages, or patient would come with recurrent pain. So the take-home message from my talk would be that complete disruption in acute necrotizing pancreatitis often leads to disconnected pancreatic duct. DPD is a risk factor for recurrent collections. However, only 10% develop pancreatic fluid collections with DPD. The need for intervention in recurrent fluid collection is less. Only 6% of the overall patients require intervention. However, interventions for the symptomatic DPD without any fluid collections needs further explanation. Thank you very much for your kind attention.
Thanks a lot. I think, Sundeep, this is excellent talk. I think really clear up a lot of doubts in terms of DP. The disconnected pancreatic duct syndrome. So I think we will meet Anthony. Do you want to introduce Nakai, or I'll introduce him?
Yeah, I will introduce Nakai.
Okay, thanks.
Next up, we will have one of my very good friends, Yousuke Nakai. He is from the University of Tokyo Hospital. He will be talking about endoscopic necrosectomy, when and how. So thank you, Nakai.
Okay, thank you. The slide is okay?
Yep, that's good.
Yes.
Okay, so I will start my presentation. Thank you, Anthony. My topic is endoscopic necrosectomy, when and how. I don't know the exact answer, but I will try. So this is a very famous step-up approach. I would say conventional. So first, we wait with a conservative treatment for 3 or 4 weeks. And if it's necessary, we will put drainage, either percutaneous or endoscopic. And then if necessary, we will do endoscopic necrosectomy. So why should we wait about 3 or 4 weeks? Because this is based on the Atlanta classification. So after 4 weeks, the necrotic area is walled off. So that's why we can approach by endoscope. So however, in some patients, we need to intervene very early because the patients are too sick or have a high fever or something like that. So this is a paper published by the Tanya. I think she is in the audience. So we have a 12 patients who had a endoscopic drainage before 4 weeks. Like this CT scan, after 2 weeks, the patient had air in the necrotic tissue. And there's some wall on CT scan, so we decided to intervene early. And in this cohort, we had a 100% technical success rate, and the complication rate, bleeding or perforation peritonitis, similar between the early drainage group and the delayed drainage group. So we think if the cavity was walled off on CT scan, we can intervene within less than 3 or 4 weeks. This is another recent paper published in GIE. They evaluate the CT scan, and there's some area of thick wall and some thin wall. But again, the resolution of symptoms are similar, both 89%. And I think the early intervention cases are more thick. So that's why time from the procedure to removal of the drains are longer in the early intervention cases. So I think even in the early drainage group, where we can perform endoscopic necrosis, necrosectomy or drainage, similarly safe. But the key point is we should intervene not too early. In this study cohort, again, the time to intervention was about 3 weeks. The earliest one was 2 weeks. So I think we should wait maybe 2 weeks, but if the CT showed some wall, we can intervene within 3 weeks. So how about the necrosectomy? So after drainage, based on this step-up approach, we should wait to see a response from the drainage. But we don't know how long we should wait. This is a multi-center consensus statement published on endoscopic ultrasound. But I should say non-consensus because there is no consensus in this paper. So this is a question 4 in this paper. So should endoscopic necrosectomy be performed during the same procedure at the drainage? Or if not, then what is the optimal interval for endoscopic necrosectomy procedures? So based on this consensus, 86% of the endoscopists thought necrosectomy should not be performed during the same procedure. And the ideal interval should be around 6 days. But if you look at the range, it ranged from 3 days or to 3 weeks. So I think there is no consensus, but on this consensus statement, most of the doctors feel endoscopic necrosectomy should be waited after the drainage. Because after fistula formation, pneumoperitoneum, perforation or bleeding complication rates are lower, and some wounds resolve after just drainage. So that's why most of the doctors believe we should wait after drainage and see the response. And if there is no response, we should perform endoscopic necrosectomy. However, now we are in the era of lumps. We are using more and more lumen opposing stent. And because of the wide lumen of the stent, we can put the endoscope very easily at the time of the index procedure. So in this multi-center retrospective analysis, they performed 69 endoscopic necrosectomy at the index of drainage procedure. And there's no obvious difference in terms of adverse events. However, they found 4.3% of dislodgement of the lumen opposing stent at the initial endoscopic necrosectomy. So we have to be very careful to not to dislodge the stent during the procedure. And this is a resolution of the world of necrosis. If you perform the endoscopic necrosectomy at the index procedure, the number of the endoscopic necrosectomy might be less. Even more than half of the patient had only one endoscopic necrosectomy. So they found the immediate endoscopic necrosectomy is the success factor. So I think if you use a lumen opposing stent, early endoscopic necrosectomy is acceptable. However, we still don't know who needs endoscopic necrosectomy because we know maybe 30 to 40% of the patients responds only by drainage. So we have to select the right patients to do the endoscopic necrosectomy. And how? So I think nobody knows. So we have some option, endoscopes, accessory devices for debridement and extraction, hemostasis, irrigation, single gate, multi-gate. There are some options. So this is my personal preference. We use EGD scope with a cap and a water jet and the CO2 insufflation. This is a must. CO2 is must because to reduce the risk of air embolism. And I think we recommend the patient to be intubated to avoid aspiration, but it's not available in unit. So we use overtube if we expect a long procedure to prevent aspiration. For the scope, like this case, this is very, very complicated world of necrosis. Like this route, we can put the regular EGD scope, but we cannot go like this. So in those cases, we use ultra thin EGD scope to approach this kind of very angulated area. But the problem is the choice of extraction devices are very limited, like a very small forceps or just irrigation. So that is a problem. So I will show you one video, very short. This is a case we put lumen opposing stent, their necrotic tissue like this. We can remove these necrotic tissue with a forceps or snares. We also use irrigation with a water jet. So we go deeper. There's some necrotic tissue. So we can irrigate water and remove the necrotic tissue with a forceps like this. There are some options for devices. We use a forceps or snare to remove the necrotic tissue. And sometimes we can use a basket or grasping forceps or nets. And there's some paper showing the endorotor for removal of necrotic tissue. And we also prefer, because we use a cap, we can also use a suction technique like a cap EMR. We can suck the necrotic tissue into the cap and remove with the endoscope. How about the bleeding? So we carefully check CT scan before drainage or necrosectomy, because there's some patient who had an aneurysm because of the inflammation. In those cases, we first do the embolization and then do the endoscopic procedure. And we have to be very gentle to avoid bleeding. And if there's a bleeding at the time of the tract dilation, we use the same balloon to stop the bleeding by balloon compression. And most of the bleeding from the cavity wall, we just watch and wait, wash, and then most of the bleeding just stop. But if it just keeps bleeding, then we will use hemostatic forceps or endoclips to stop the bleeding. But actually, this is very difficult to stop. I will show you the case. This is a patient who had two cavities, one very close to the stomach, one in the deep. There's a communication, so we can put the nasocystic drainage tube, but it didn't resolve. So we decided to balloon dilate the fistula between two cavities to do the necrosectomy. So this is a very small cavity. We can put the tube, but there's some necrotic tissue in the deep area. There's some pus coming from the deep area. So we put the guide wire and then balloon dilate to put the scope into the deep area. So after dilation, we can put the scope inside. But however, there must be bleeding like this. So we use a balloon to compress the bleeding point. However, it didn't stop. So we went to the CT room, check the CT scan, and then go to the IVL with the scope inside. So with this angiogram, we thought this is a bleeding point. So at this point, we deflate the balloon. So there's some extravasation. So we embolize this artery and then the bleeding stopped. So we had a very same case. There are two cavities close to the stomach and the paracolic area, another cavity. So there's some very narrowed tract. But at this time, we decided to not to dilate this tract because we had a previous case. So we decided to put another lumen opposing stent, and we successfully performed the necrosectomy. So we still run our case. So there's no right answer to how to do the necrosectomy, I think. How about the irrigation? So this is, we can put a nasocystic drainage tube and put the saline or something to irrigate the cavity. So this is a comparative study with and without nasocystic drainage tube. So in this study, if you use a nasocystic tube and the irrigation, the stent occlusion rate was low and the success rate was high. So in most cases, we put this kind of nasocystic drainage tube for irrigation. So however, the previous consensus paper showed about half of the endoscopists recommend nasocystic tube. So there is no consensus among these endoscopists. So, and we can also use a hydrogen peroxide or antibiotics within the saline. However, there's no comparative study, so we don't know which is better or not. So the conclusion is nobody knows how to do it. So we do whatever it takes. However, this is a paper from Shyam. I think he showed some new paper, but this is just published in Journal of Clinical Gastroenterology. They use a cap-fitted EGD scope water pump and for debridement, snares, and forceps, and irrigation with gentamicin, and they also use hydrogen peroxide. With this algorithm, they show the number of necrosectomy sessions decreased, and also the accessory they use is did decrease significantly. So I'm not sure this is how we do it, but I think we should find the standard protocol for each center. We have some protocol, so I think still there's some difference from center to center. So we need more valid data in multi-center prospective studies. Thank you for your kind attention.
Thanks a lot, Nakai. Very good talk. I think you helped to answer a lot of questions.
Yeah.
Posing a lot of questions, you just managed to anticipate those questions and answer them all. So I think, Anthony, you want to go to the Q&A?
Yeah, so I think in the questions, one of the questions that was raised was, have you had any experience with the new device, which is called the over-the-scope grasper, which is produced by Ovesco? It's kind of like a big mouth thing, which you can bite on the necrotic material. So have you had any experience, or Marco or anyone from the States, have you had any experience with this device?
Well, I have not. We have been working a lot with the endorotor lately.
Endorotor, yes.
Yeah, we just completed a prospective cohort study there, and we are quite enthusiastic about this. And we are on the verge of starting within the pancreatic study group a randomized controlled trial to see if that truly makes a difference as compared to what we use conventionally.
Okay. Can you explain slightly to those who are not familiar with the device how it works?
It's a kind of an extended catheter that you push through the working channel into the cavity, and you can see visually, endoscopically, you see the catheter coming out into the view of your endoscope. And then at the tip of the catheter, it's hollow, and there's a circulating knife. And by creating an under pressure in the catheter, kind of tissue is sucked into the hollow part of the distal part of the catheter and being chopped off by the circulating knife. And what I like about it is that it is very controlled. You see exactly what you're doing. And depending upon the amount of negative suction you apply, and depending upon the size of the catheter, because there are now multiple sizes available, it can go slower or faster. And what I like is you have control and you can avoid intervening vessels, which sometimes, of course, can cause a massive bleed, as was shown very nicely in this presentation.
I think I came across this device like 5 years ago, and they started marketing it as a tool for mucosectomy. So it was it allowed suction of the mucosa, and it was like cutting the mucosa, but at the end you cannot get pathology, so it didn't work very well. Are there any risk of cutting into a vessel?
Sorry?
Is there any risk of inducing bleeding when you're sucking the tissue?
Oh, you know, I think with every device that you use, there's a risk, in particular the way we do it now, because let's be fair, much of what we now with necrosectomy is kind of blind. You know, you just pull out chunks of tissue and, you know, hopefully nothing starts to bleed. I think this is more controlled, again, because you see exactly what is happening at the tip of your endoscope. You see the tissue being sucked in, and it goes step by step. It's not like it's sucking in a huge chunk of tissue. It goes step by step.
Mm-hmm. Okay. And I think Nakai was alluding to this on whether we should perform early or delay necrosectomy. So Nakai, what is your suggestion now? Do you do early or late?
We still wait a few days, but actually...
2 days is not late.
So before the procedure, before the drainage procedure, we expect which patient needs a necrosectomy. If the patient had a very huge evacuated ward of necrosis and a high fever, the patients are likely to need a endoscopic necrosectomy, but still we wait a few days.
Okay. How about Marco? Are you doing early now with the endorota?
So if you mean with early that we do it immediately when we have drained the collection, so we have punctured the collection and kind of created the fistula, no, we don't. We still await kind of maturation of that fistulous tract for a few days, minimally like 2 days. I'm not sure if that's truly necessary. There are others who do it immediately, and what I hear, they don't encounter too many problems. But what we find is normally when you have a patient who's very sick, just draining the collection itself kind of clears up the clinical situation greatly, which means that you can do the true necrosectomy if the patient still, remains to have fever in a much more controlled session or way during the second procedure.
There's a follow-up question on how many sessions do you need to do with the endorota? How many sessions of necrosectomy? Can you do it all in one?
We have cases where we did only one, but we have compared so far in a prospective cohort series, and we need on average somewhere between 2 and 3 procedures in some patients with very extensive necrosis. But again, the true answer, whether the endorota is truly of benefit, can only be answered in a randomized controlled trial. Because you always have patient selection, and we as researchers sometimes like to see and find what we believe in. So I think it's too early days. I like the technology, the concept and the way it feels, and exactly as you were telling, it comes out of a complete other indication, the mucosectomy, where it didn't work. And I'm curious. I'm hopeful that it will add something of benefit to our armamentarium of instruments. Okay,
I'm going to move to Sundeep. So Sundeep, you mentioned your management protocol for disconnected duct. So I think in the past, a lot of people would insert a double plastic stent permanently. So now with your study, you're suggesting we do not need to actually do so. Most of these patients, even if they have recurrence, they won't be symptomatic. Is that a good summary?
Yes.
So I'm curious. You at the end of your talk, you showed a few cases where you've tried to drain either the disconnected part as well as the transpapillary drainage. So you try to drain both parts. So question number 1, for the EUS drainage, usually we would end up with a single pigtail or a single straight stent. How do you deal with this long term? Do you ask them to come back periodically to change stents, or you just leave them in permanently, or what would you do?
We leave them permanently, just like we manage the pseudocyst with a plastic stent. In pseudocyst, we have a double pigtail. Here it's a single pigtail or a straight stent. Mm-hmm. Unless he has symptoms, so we go by the symptoms only, because most of these ducts would drain, if not through the lumen of the stent, they will drain beside the stent like a wick.
Mm-hmm. And the second question, if you do a transpapillary drainage, you showed in your slides, sometimes if you inject contrast, you push it through, you would see the collection from the abrupt cut, the cutoff of the duct. So when you place the PD stent, would you place it transpapillary through the PD pancreatic duct into the collection, or you would just put it in the PD?
So we place in the PD. So those cases that we showed were the ones which had symptoms, or at the time of removal of the stent, we found that we can bridge the upstream duct, and the stent was placed in the duct.
Okay, so you don't go across the duct into the collection so that it drains both parts.
No, we try to go into the duct so that then the duct remodels around the stent with a similar logic that is done in the biliary stenting. In the benign biliary stricture, you place one or many stents. So the remodeling occurs around the duct, around the stent. With the same principle, we try to hope that this remodeling around the stent would ultimately keep the two disconnected segments connected by the bridge of the stent.
Okay. There's a question about the use of hydrogen peroxide. So I guess anyone here uses hydrogen peroxide? Can you show me your hand amongst the faculty? Sundeep?
Yes.
Marco,
So
you don't? Okay. So Sundeep, why do you use it?
So we use it in patients who have symptoms after the index drainage with metal stent of fever. And if we go inside the cyst cavity and we find that the debris is not loose and floating around, but it's adherent to the back wall, to the faraway wall. And there's no way that we can scrape it off. We don't have that rotablator device which Marco was mentioning. And our preferred device generally is a snare, a braided snare to take it out. So in such situation, we use a nasocystic tube to irrigate it periodically at 8 hourly intervals. The premise is that it loosens up the debris and it makes the subsequent session of direct endoscopic necrosectomy much easier.
Marco, why don't you use it?
Well, you know, show me proof that it makes a difference. You know, I've even heard, you know, places where they used sugar-free Coca-Cola to irrigate the cyst in an attempt to clean out. Yeah, I would first like to see the proof. Where does it truly kind of make the necrosis more loose, and does it add something to? Otherwise, it's just another kind of magical type of handling. And we do already so many magical types of handling, of which we don't know exactly whether it's of benefit to the patient. So
we have a benefit of having a hepatopancreatic surgeon here. So Kelvin, what do you think? So you have done a lot of open necrosectomy or maybe some laparoscopic. Yeah. Do you think hydrogen peroxide would help when performing necrosectomy?
Well, I've tried it. I tried the hydrogen peroxide during the open necrosectomy. The only reason that I use is try to sterilize the fuel, not to make it liquefy. So of course it's not evidence based. So it's just a personal interest. Okay. I tried several times. It did work.
Okay, so you have the endorsement of the pancreatic surgeon, Sundeep. Okay, so I think Lawrence is reminding me that the time is short, so we should move on to the next session. So
Dongwan just came up.
Hello, Dongwan. I think he just sort of froze.
I think he and Natalie can actually chair the next one.
Yeah, he's in the car.
Okay, sure.
Siupo is not here. Siupo is not here, so I think maybe Dongwan can share with, moderate with Natalie.
So perhaps Natalie, you can introduce the next speaker first.
Sure, yeah. So it's really my pleasure to introduce our next speaker, Professor Marco Bruno, who's the Director of Endoscopy in the Department of Gastroenterology and Endoscopy, and Hepatology at the Erasmus Medical Center in Rotterdam, the Netherlands. And his talk is entitled Management of WOPN, Lessons Learned from the Dutch Pancreatitis Study Group. Please, Professor.
Thank you very much. So yes, I'm going through history and I'm going to show you some of the thoughts we had within the Pancreatic Study Group in the Netherlands, and which of the questions we try to kind of scientifically address and answer. These are my disclosures, work for companies and positions in societies and governmental institutions. Of course, we all know that acute pancreatitis is a very common disease, not only in the USA, but also in Europe. One of the most common reasons for hospitalization, also at my department, we see many of these patients. Of course, not all patients then develop, for example, a necrosis or affected pancreatic necrosis. But we also know that the incidence has been steadily increasing by about 5% annually. So also from a hospital perspective, this is an important category of patients, in particular because the more ill patients need a lot of multidisciplinary care. Now, if we look at the severity of mortality, luckily, 80% of pancreatitis is mild. You don't develop necrosis. And the mortality in this group of patients is fairly low, far below 5%. but 20% of patients do develop severe pancreatitis with peripancreatic necrosis and organ failure. 70% is sterile, and 30% will get infected necrosis. And there is a big difference in the prognosis of these patients, because in the case of sterile necrosis, the mortality rate is between like 9 to 12%, but in case of infected necrosis, the mortality rate rises up to 25%. And it makes it a very severe disease, and a disease where we as physicians and interventional endoscopists and surgeons can do potentially a lot of good, but we can also do a lot of harm if we derail the disease course of the patient. Now, to give you a short introduction into the Dutch Pancreatitis Study Group and the history and the goal, it was founded quite some time ago. When I prepared these slides, I was kind of surprised that we already exist for 18 years. And in fact, the goal of the study group, or the Dutch Pancreatitis Study Group, was to have some form of consultation for colleagues who are not so much into HPB and not so much into care of patients with severe pancreatic disease. So we have a consultation line, and I get like emails and consultation emails like almost every day from colleagues around the Netherlands, where with a group of 8 colleagues, we give consultations to what we would do in such a case. Centralization of care, so advanced treatment we try to center in a few hospitals in the Netherlands. And of course, we would like to do, and we do a lot of multi-center research. In a very small country, because like you see below, we only have 17 million people. Many Indian and Japanese cities have more inhabitants in one city. Now, this multi-center collaboration, we do this because, in particular, the subjects of pancreatitis that we are interested in, for example, patients with infected necrosis, that's a relatively low incidence, and it's difficult as a single center to do meaningful research. Disease complexity, we like to do multidisciplinary research. We work a lot together with the intervention radiologists and the surgeons. Of course, if you work together and you build up a history together of doing good research, you have better chances for funding. We have, of course, much better patient accrual, and we also keep this alive because we divide the credits. So we do joint studies, and we have a rotating principal investigators between the different centers. We already have published quite some studies, many studies about how to improve the outcome in early phase of pancreatitis, probiotica. We just published this trial in Lancet last month about early sphincterotomy in patients with predicted severe pancreatitis. We published on early on-demand nasogastric feeding, but we also do a lot of work in the subject that we are talking about right now, which is to improve intervention in severe infected necrotizing pancreatitis. And in fact, you see all these acronyms: PANTER, Penguin, Tension, and Pointer. I will go through all these studies. And in fact, I was happy that I can reveal with you for the first time ever now, online or in a symposium, the results of the Pointer trial, which I think are very interesting. And that's about whether you should do the necrosectomy and the drainage very early on in the course of pancreatitis, or whether you should wait for at least 30 days. Now, the guidelines, the IAP and AP guidelines for intervention tells us that clinical suspicion of or documented infected necrotizing pancreatitis with clinical deterioration, preferably when the necrosis has been walled off, that's the indication to do an intervention in necrotizing pancreatitis. And in the absence of documented infected necrotizing pancreatitis, ongoing organ failure for several weeks after the onset of acute pancreatitis, and again, preferably when the necrosis has become walled off. There's always confusion when you talk with colleagues who are not so much into pancreatology about what is a pseudocyst and what is a necrotic collection and what is infection. And this, I think, is a nice graph showing what we see as early and what we see as late. And pancreatic injury can both cause an acute fluid collection, which can become infected or non-infected. And you have the acute necrotic collection, which also can become infected and non-infected. And then we have the early and the late phase, where kind of arbitrarily, because of all the experience throughout many decades, has been set at around 4 weeks. And again, also in the late event, when the acute collection has evolved into a pseudocyst, When the acute necrotic collection has evolved into vault of necrosis, it can again be affected or non-infected. Now, when does encapsulation occurs? And I think this is an interesting graph where we look through our own data of the Dutch Pancreatitis study group, and you see here in weeks, and you see in color how much encapsulation occurred. So in green, complete, in yellow mostly, in orange partly, and in red none. And you can see that somewhere between 4 and 5 weeks, about 50% of collections are kind of completely encapsulated, but at 5 weeks, kind of all cases are complete or mostly encapsulated. And here you see many patients whom that's not the case yet. And then it's the question, can you do anything with regard to drainage, either percutaneously or by endoscopic means? We did an international survey to find out, because we were preparing the Pointer trial, which I will tell you the results later on, because we wanted to get a feel for what people are kind of doing now in actual practice, because we had the belief that many colleagues indeed wait until 4 weeks or even later to do the drainage, but that's not true. As you can see from this graph, when patients have clinical signs of an infection with gas on CT scan, you can see that a fair number of colleagues already perform drainage quite early on in the disease course. When there's no gas on CT scan, but only clinical signs, this is much lower as compared to when there's gas present. But in clinical practice, at least in the experts that we approached to do this survey, it was not that they always wait until 30 days or 4 weeks until full encapsulation kind of occurs, as I showed you in the last slide. Now, diagnosing infected necrosis, we know you can see imaging on gas CT, which is kind of a sure sign of infection, but it happens in about a quarter to maybe 40% of cases. What we did in the early days, and what we have been doing in the Pointer trial now quite often, because we wanted to have a fairly early kind of diagnostic tool to show whether a collection was infected, you can do fine needle aspiration, which is very rarely false positive. Sometimes it's false negative, but it's in good hands. It's a reliable tool to show whether a collection is truly infected. But we have also learned, at least from our experience in the Dutch Pancreatitis study group, that we are good, we are fairly accurate in predicting whether a collection is infected. And in this postponed strategy, where you follow up the patient over time, and you look at the clinical condition and the clinical course, we are kind of 90% accurate in predicting when a patient goes worse, whether he or she has an infected collection. Now, how to prove clinical outcome? So first question is a step-up approach for infected necrosis superior to open necrosectomy? The second question is endoscopic treatment for infected necrosis superior to open necrosectomy or a step-up approach? And third, what is the ideal timing of intervention of infected necrosis? And in fact, these 3 questions took us about 12 years in the Dutch Pancreatitis study group to address. And for that reason, we did many studies amongst 3 randomized controlled trials, of which I will share the results with you. Now, open necrosectomy, traditionally, a long time ago, complete removal of infected necrosis, but high morbidity, high mortality, the risk for pancreatic fistula, and because you take out a lot of pancreatic tissue, not only the necrosis, but also viable pancreatic tissue, you run a higher risk of pancreatic insufficiency. And a surgical step-up approach, less surgical stress on very critical patients. You do this percutaneous retroperitoneal catheter drainage, and then you use the drain as a kind of a guide and guidance to go in and to remove necrosis with a minimal incision, a minimal surgical trauma to the patient. In fact, that was the setup of the Panther study, the step-up approach of open necrosectomy, which we published in 2010 in the New England Journal of Medicine. And what we found in that study is that in patients with open necrosectomy, the composite endpoint of death or major morbidity occurred much more often in 69% of cases as compared to the minimally invasive step-up approach, 40%. And this was not only statistically significant, but also, of course, clinically significant and relevant. A new onset multi-organ failure, 42% versus 12%, for example. And as was alluded to in some of the previous talks already, very important, I think, is the observation that you do not need to do a necrosectomy in all cases. In this study, in 1/3 of the patients, we did not need to do any additional necrosectomy besides the percutaneous drainage. As always, important, and what we now kind of try to do as a common goal within the Dutch Pancreatitis Study Group, that we extend every study for 5, 10, and we are going to do that even for 20 years, because we're going to follow up all these patients kind of indefinite. We want to do true long-term follow-up, and that's what we did in the Panthers trial already, and we published that a year ago in Gastroenterology. We went back to the patients, 88 patients whom we treated, and you can see that still, also after longer term follow-up, the conclusion of the original study stands, where with the minimal invasive step-up approach, significantly fewer patients reached the primary endpoint, 44 against 73%, less exocrine insufficiency, and a trend towards less endocrine insufficiency. It's always worthwhile to mention also that there's no difference in recurrent or chronic pancreatitis, the total of endoscopic or surgical intervention, the quality of life, or cost. And we concluded already when we did the original publication, but now still remain with that conclusion after the longer term follow-up, that the step-up approach is superior on short and long term as compared to the surgical approach, the open necrosectomy. So the logical evolvement was the percutaneous drainage followed by surgical débridement, where it's an initial choice of patients with the necrotizing pancreatitis, what has a mortality and morbidity of around 40%. And the alternative, what has evolved over the years, is the endoscopic treatment, where we've seen some very nice examples. We do the transluminal drainage, and when required, we make the fistula bigger and we follow endoscopic necrosectomy. And we have much more experience these days. So the logical conclusion is, or the logical follow-up would be to do a trial. And we did a kind of pilot trial, the Penguin trial, which we published in the JAMA, where we compared the endoscopic transgastric surgical necrosectomy for infective necrotizing pancreatitis between these two modalities. 22 patients, so it's a fairly small study, 4 hospitals, endoscopic transgastric necrosectomy comparing to surgical necrosectomy, and the outcome was not morbidity or mortality, but a pseudo endpoint, in this case, pro-inflammatory response. And the results were almost too good to be true, because you can see that in 24 hours after the drainage, but even follow-up up to a week, in the transgastric necrosectomy, the inflammatory response was much lower as compared to the surgical response. Which you could attribute to a kind of lesser trauma that you apply to patients. And even maybe too good to be true, if we then looked at the endpoint that we normally use in the studies, but again, I want to show you, these are fairly small numbers. Major complications of death occurred only in 20% of the patients treated with endoscopy, but 80% in cases with surgical necrosectomy. And the new onset organ failure, multiple organ failure, 0 versus 50%. So this would kind of almost imply that you should stop immediately with doing surgery and do only endoscopic treatment. Also, pancreatic fistula, of course, occurred at a much lower rate, 10% versus 70%. But as I will show you, it's always good not to only rely upon such a pilot study and always do a good randomized control trial, because the results are a little bit more balanced when we did the tension trial, which we published in the Lancet a few years ago. And this is about a randomized control trial between the endoscopic and surgical step-up approach. In this study, opposed to the pilot study, you can see that major complications or death were kind of exactly the same between the two. I do want to point out that if you look at the new onset organ failure, you look at the secondary single endpoints, they occur all in a lesser frequency as compared to the surgical step-up approach, but they don't reach statistical significance. So you could argue whether there's an issue with sample size, but we have to be fair within this trial with regard to the primary endpoint. We could not show a difference between the two modalities. Death, 18% versus 13%. Pancreatic fistula, there was a difference, 5% versus 32%. Days in hospital, that was significantly lower in the endoscopic step-up approach versus the surgical group, and also costs were considerably lower in favor of the endoscopic step-up approach, but again, not with regard to the primary endpoint. Now the important issue of when to intervene and to drain. What is the optimal timing of intervention for suspected or confirmed infected necrosis? And here it says that you should postpone until at least 4 weeks after initial presentation. And within the pancreatitis study group, we had a discussion that, you know, these patients take up so much time of in-hospital time and resources. Couldn't we drain much quicker, much sooner in the course of the disease, at the time when we could see on a CT scan a collection of fluid, and then when possible drain it endoscopically, but we already suspected that most often we would have to do that percutaneously, which in fact also was the case. And would that not then kind of prevent that patient from developing much more severe disease, and would that not be beneficial for the disease course of the patient? So the Pointer trial was an investigator-initiated multi-center randomized controlled superiority trial. With this PICO, patient with infected necrotizing pancreatitis, immediate catheter drainage within 24 hours after detection of a collection, or postpone catheter drainage until collection has walled off. And then outcome was again composite endpoints, mortality, non-supportable failure. And we also looked at the primary endpoint, the comprehensive complication index, combining all the complications during a 6-month follow-up. And I want to bring into your memory the slide I showed you, that a substantial proportion of colleagues already do drainage before 30 days and before the collection has kind of walled off. So these are the results of this study, which we're going to present officially during the UEGW tomorrow or the day after tomorrow. So we randomized in total 104 patients in 22 hospitals, and this mean complication index was 56 in the immediate drainage group, and I cannot read it because it's in front of my slide, 48 in the postponed drainage group, and you can see there's no statistical difference between the two groups, between early or delayed drainage. Also no significant drainage between immediate and postponed drainage in the rate of new onset failure, organ failure or death. So we were not able with early drainage to make things better for the patient, to prevent things from occurring. And also it came at a cost because the median number of drainage procedure in the early cases was 4 and only 1 in the postponed drainage group. Median hospital stay was 48 days in the early group and 35 days in the late drainage group. Again, as was the original observation in some of our other trials, about 1/3 of the patients in the postponed drainage algorithm were successfully treated only with antibiotics and only with drainage. So lesson learned and summary kind of conclusion from what we have done so far in the pancreatitis study group with regard to infected pancreatic wall necrosis. A step-up approach for infected pancreatic necrosis superior to open necrosectomy. I think an important lesson to keep in mind is the 35% of patients that do not require any type of debridement after percutaneous drainage. An endoscopic step-up approach is not per se superior to surgical step-up approach, except for the occurrence of pancreatic fistula, length of hospital stay, and overall cost, which by itself for us is the rationale to stay with the step-up approach and to be the preferred approach in our group. And immediate catheter drainage is not superior to postponed catheter drainage. Thank you.
Wow. Thank you so much, Professor Bruno. That was amazing. I think it answers almost all the questions. I'd like to invite Dong Wan to introduce our next speaker before we do the discussion at the end of the session. So Professor Dongwan.
Thank you, Nantali.
Yeah.
I'm sorry for the late joining this wonderful meeting. I can see many famous endoscopists here. I'm going to introduce next speaker, who is Dr. Kelvin Ng. He is working in Chinese University of Hong Kong. He is a HBP surgeon, and he will talk about the current role of surgery in management of WOPN.
Thank you.
Dr. Kelvin Ng?
Yes, thank you. Let me share my PowerPoint first. Okay, good evening. I'm Kelvin Ng from Chinese University of Hong Kong. I'm working with Anthony Teoh, and thanks Anthony for inviting me to this wonderful webinar talking about the drainage of the pancreatic necrosis. And it's my great honor to be an HPB surgeon in the Society of the Endoscopic Ultrasonography. And also to talk after the Professor Bruno, I must say that many of my material was already talked about by the Professor Bruno from the Dutch pancreatic study group. So I will try my best to illustrate to you what is the current role of the surgeon in the management of the wound. So I have nothing to disclose. And first, I would like to focus the role of the surgery in the management of the infected pancreatic necrosis, because to my understanding, the definition of wound is just a time dependent for more than 4 weeks from the onset of the symptom. Okay, so just a bit of epidemiology. The acute pancreatitis is accounting for 4.9 to 35 per 100,000. And as you know, alcoholism, gallstone are the major cause. And about, as mentioned by the previous speaker, about 1/4 of the patients with the acute pancreatitis will present with severe complications such as necrotizing pancreatitis. And if the patient presents with the necrotizing pancreatitis, the mortality rate will range from 10 to 20%. That's the history of the surgical management of the necrotizing pancreatitis. If to go back to 10, 20 years ago, surgeon has a major role in the management of the necrotizing pancreatitis. In the early 80s, the surgeons are the major physician, are the major person to look after those patients with NP by performing the open necrosectomy. In 1980, surgeon is still the major person to look after those patients. Not until the early 1990s, conservative management was first advocated in view of the high surgical mortality. And the controversies of the exploratory laboratory versus total pancreatectomy in the severe pancreatitis was first raised in the early 1995. And from 2007 onwards, the benefit of the delay necrosectomy was first brought up. In the history of the open pancreatic necrosectomy, it has been said to be the gold standard for the treatment of the necrotizing pancreatitis. The indication, as you all know, is infected pancreatic necrosis, failure to improve after the conservative treatment, and in those patients with the acute abdominal catastrophes, for example, uncontrolled sepsis, perforated viscous, bleeding from the erosion vessels, and also the abdominal compartment syndrome. However, the complication rate and mortality rate is relatively high, with the complication rate up to 95%, mortality up to 40% in those patients. And as you all know, in the history of the open necrosectomy, we have to take in the needle to prove that there is an infection of the pancreatic necrosis. If there is an infection, or the presence of gas in the collection on the CT scan is indicated for the intervention by the surgeon. Otherwise, it will be managed conservatively. That was in the history of the pancreatic necrosis treatment. Until 2012, because of the classification of the acute pancreatitis, we all know that it is divided into sterile and infected necrosis. And if there is an infected necrosis, that is the necrotizing pancreatitis, if the onset is more than 4 weeks' time, there will be roll-off necrosis. So at that time, the definition of WOPN was first advocated, and then the conservative treatment and so-called the step-up management was first advocated from that time on. So the question is, as a surgeon, when to intervene by surgery in order to get the maximal benefit for the patients. And many studies have proved that the timing of the surgical intervention is divided into early phase and the late phase. If the surgery was going to have, is being done in the early phase, it is associated with high risk of bleeding from the vessels and also the various surgical complications such as vascular injury and bowel injury. Mortality rate is up to 65%. And it has been shown that early phase surgery is an independent predictor of the poor prognosis for those patients with necrotizing pancreatitis. Therefore, late intervention seems to be more applicable. It allows better demarcation between the necrosis and the viable tissue, and it has been shown that the mortality rate is down to less than 30% in specialized center for late intervention by surgery. That's the Panther trial has been mentioned by Professor Bruno. It's a very famous trial from the Dutch pancreatitis study group. And as mentioned that for the step-up group, it is shown to be much better than the necrosectomy group. And the content I won't bother more. But the conclusion, I must say once again that for the step-up group, compared with the necrosectomy group, open group, it's associated with less complication of death and less onset of the multi-organ failure, and also less incisional hernia and less new onset of the diabetes mellitus. And 7 years later, the group published and the long-term follow-up result in the gastroenterology, again showing that for the step-up group, it is much superior than the open group in terms of the less death, less incisional hernia, exocrine function insufficiency, and also the endocrine insufficiency. The conclusion is obvious that the step-up approach is superior to the open necrosectomy approach without increasing risk of the re-intervention. And this is the latest study from the Edinburgh University showing that there is an improved mortality in the necrotizing pancreatitis with a multidisciplinary, minimal invasive step-up approach as compared with the open necrosectomy cohort. It has shown that if you adapt step-up approach, there will be 5 times improvement in the 90-day mortality, 5 times improvement in 1-year mortality, and 1.5 times improvement in organ failure rate, and also 2 times higher bleeding rate compared with the open necrosectomy group. So let's come to the modern treatment algorithm of the infected pancreatic necrosis. If you have the infected necrosis, the main treatment first within the early phase must be the medical treatment and also the percutaneous drainage if possible. If this is the only, if the patient condition improve, then it will need no further treatment. If the condition worsening, then we'll have the minimal invasive so-called the step-up approach, which can be, again, the percutaneous necrosectomy, endoscopic necrosectomy, and also retroperitoneal necrosectomy or laparoscopic one. If all these approach fail, then we go to the open necrosectomy. So for the modern treatment algorithm, surgical intervention should be considered when there is a clinical deterioration despite maximum percutaneous or MRS drainage of the necrotic pancreatic tissues, or if there is happening of the acute abdomen in terms of the bowel perforation of ischemia, intra-abdominal bleeding, and also the intra-abdominal compartment syndrome. So what are the approaches for the surgery for infected pancreatic necrosis? It can be classified into transperitoneal, retroperitoneal, transgastric, or it can be done through the open approach, laparoscopic approach, or combined endoscopic approach. This is the traditional transperitoneal open necrosectomy approach. It makes use of the subcostal or long midline wound. The surgeon will go into the retroperitoneal region through the lancet and also the left and right paragolic cutter through the Teoh or Matthews maneuver. By going into the lancet and looking at the all the necrotic tissue, we'll use the blunt dissection or by ring forceps for the necrosectomy. Here it shows the intraoperative photo where I performed just half years ago for a patient with a very severe necrotizing pancreatitis, which did not respond to maximum intensivist treatment. And the patients developed acute abdominal compartment syndrome. Therefore, we have to go in to do the necrosectomy. So by resecting all this necrotic tissue out, we put in the two wide bore, so-called the sum drain, which is the irrigation drain, and then we close the abdomen. And for this drainage, we can have the continuous irrigation of the abdominal cavity by the cold saline in the early postoperative period in order to wash out the dead tissue. And this is all the necrotic tissue that we have removed during the operation. The common complication occurred after the open necrosectomy, I must say. In the early phase, we might have the bowel perforation, intra-abdominal bleeding, most commonly as a result of the shoulder aneurysm from the major vessel, like gastroduodenal vessel or other great vessel around the pancreas. We have the wound adhesion. In the late phase of the open necrosectomy, we might have the incisional hernia, antral or pancreatic fistula, or pancreatic insufficiency. Here it shows that the patients with the open necrosectomy, he developed a fistula, the perforation over the right ascending colon, which we need to go in to resect this colon out. Another patient illustrates to you the happening of the bowel perforation after the open necrosectomy. This patient again had very poor condition. In initial phase, we failed the conservative treatment. After the percutaneous drainage, then we have to go in to do the open necrosectomy. And after the necrosectomy, we found that a few days later, he developed a pneumoperitoneum with the small bowel perforation. And we go in, we try to repair this perforation primarily. However, this repair site break down a couple of weeks later, and then he ended up with the small bowel stoma afterwards. And luckily, he can go home about few weeks' time. Another approach for the necrosectomy is so-called the video assist retroperitoneal drainage. Initially, we put in the percutaneous drainage into the retroperitoneal region, and then we wait for 2 to 4 weeks' time, and then we do the video assist retroperitoneal drainage either by open approach or by so-called the endoscopic approach through the retroperitoneal drainage tube tract. This is the usual endoscopic transgastric necrosectomy, which has been illustrated to you all by the previous speaker through the so-called the posterior gastric wall. Either we put in the lamps, and then through the endoscope, we can perform the endoscopic transgastric necrosectomy. So which approach is more superior than the others? There is a meta-analysis on all the retrospective study and also one RCT on comparing the retroperitoneal approach versus the open intraperitoneal necrosectomy in the step-up approach for the infected necrotizing pancreatitis. And it shows that the retroperitoneal approach is much superior than the open transperitoneal approach in terms of lower postoperative complication rate, lower hospital mortality, higher technical successful rate, and also shorter operative time and also shorter hospital stay. And this randomized control trial has been illustrated to you by Professor Bruno that endoscopic step-up approach is much superior than the surgical step-up approach for the infected necrotizing pancreatitis in terms of although the similar complication or death rate or similar mortality rate, but the pancreatic fistula rate is much lower in the endoscopic approach, and also the hospital stay is much shorter in the endoscopic step-up approach. More recently, surgeons in the United States have advocated laparoscopic transgastric necrosectomy. That is another new approach to do the necrosectomy. In this approach, through the laparoscopic technique, we can have we open up the anterior gastric wall, and then with the help of the laparoscopic ultrasound, we open the posterior gastric wall and then do the necrosectomy through the transgastric approach. And afterwards, we just suture up the both anterior and posterior gastric wall. So the recent paper published in Endosurgery just a few months ago is a single-center retrospective study on the result of the surgical transgastric necrosectomy for the necrotizing pancreatitis. The technique the surgeons surgeons use either this open TGN approach or laparoscopic TGN approach. The result is from the 3 high-volume centers in the United States involving 178 patients. For the either open or laparoscopic TGN approach, the procedure was done more than 30 days after initial diagnosis. The median hospital stay is around 8 days. Postoperative complication rate is 38%, and mortality rate is only 2%, with the median follow-up period of the 20 months. About 90% of the patients had complete clinical resolution of the symptom, and the remission rate is around 20%. So what are the pros and cons of this new surgical transgastric necrosectomy approach? The pros is that it converts a traditional 2-stage necrosectomy to potentially 1-stage necrosectomy. Just you do the necrosectomy through the gastric wall directly into the retroperitoneal region. It has excellent symptomatic resolution, shorter postoperative hospital stay. However, it did associate with some disadvantage in that it has considerable high readmission rate and also some reintervention rate. It is difficult to examine the rest of the peritoneal cavity because it just opened up the posterior gastric wall and go in the retroperitoneal region through a small window. And then it is limited to the patient who have not undergone other preceding surgery. Otherwise, you cannot do the laparoscopic transgastric approach. So just early on, the speaker has shown to you that the recent AGA clinical practice update in the expert review on the management of the pancreatic necrosis did illustrate to you that different approach to the debridement, it depends on the location of the retroperitoneal or so-called the perigastric necrosis. If it is just retrogastric region, we can achieve we can perform the endoscopic or laparoscopic approach. However, if the perigastric necrosis extend more than that, away from the retrogastric region, either in the left and right paracritic region, then we might need open necrosectomy approach. And in this guideline, it has been stated that open surgical debridement maintains an important role in the management of the pancreatic necrosis, even in the modern era. And for the open approach, it might be the best treatment for patients with large burdens of necrosis, which is distributed diffusely throughout the abdomen. Therefore, ladies and gentlemen, I'd like to conclude my talk by saying that step-up approach nowadays become the modern standard of care for the patient with severe acute pancreatic necrosis. Pancreatic necrosectomy should be delayed for 2 to 4 weeks to avoid substantial morbidity or mortality, unless there is evidence of acute abdominal syndrome. And also, new approach, either the video-assisted retroperitoneal approach or transgastric approach, still need further evaluation. However, open necrosectomy still play an important role in the treatment algorithm, as stated by the AGA guideline. And last but not least, I must say that this, the treatment of the necrotizing pancreatitis, it did involve multidisciplinary approach involving the intensivists, gastroenterologists, endoscopists, and not at least the surgeons. Thank you for attention.
Thank you, Kelvin Ng. It was a well summarized lecture about the surgical role in surgical necrosectomy in patients with necrotizing pancreatitis. I think it's time to Q&A and discussion session. So we can receive some questions or comment from the audience and also from the panelists.
That a lot of the questions have been answered during the lectures, but I have a question for Professor Bruno. When you've come across patients who have had CT scan showing gas formation within the pancreatic necrosis, but the patients don't have that much of a symptoms. They may have a little bit of abdominal discomfort, more like a bloating, but they can eat without needing the NG tubes, and they have no fevers, no pain. Although the size of necrosis is generous, would you drain these patients?
Well, if you have gas in a collection, there are two possibilities. It's gas due to a bacteria, or there's a spontaneous fistula that occurred between the collection and the GI tract. Well, in the first case, it's only a matter of waiting until the patient gets more sick. And usually that doesn't take too long. It is a matter of hours to days before the patient gets more sick. With regard to spontaneous drainage and fistula formation, in particular when that occurs in a non-infected collection, which is quite rare, that collection gets infected. And in my experience, that doesn't resolve spontaneously that often. I can remember cases where we had to drain, but again, the situation is quite rare. We had cases kind of where the opposite occurred, where the patient was quite sick, and we scheduled the patient for drainage, and that we scheduled it the next day, and the next day the patient was doing much better. And then we made a CT scan, and we saw a lot of air in the collection, and that kind of was a proof that a spontaneous drainage had occurred. Now, even in those patients, in the majority of cases, we find that we still have to drain because the fistulous tract is just not good enough to ensure complete drainage, in my experience.
Okay. Okay. Very
Marco, congratulations on your pointer trial. So it's very interesting results. So you found that the early drainage arm was actually worse. You had to have more re-interventions, and what was the other finding?
More re-interventions, longer hospital stay.
Okay.
And in fact, everything we thought that we could do better with regard to the outcome of the patients was not materialized. It was not that patients, more patients died or had larger complications. That was not the case. It was also a superiority trial. Don't forget that. It was powered to show superiority, which we didn't see. Because we had a lot of discussion before we started this trial. Because those that were kind of were arguing, this is a very sick group of patients and you delay treatment on and on and on. And very often these patients are lying in ICU, which is, these beds, at least in the Netherlands, are very scarce. It's very expensive. So everything we can do, even from a cost perspective, not only from a patient perspective, but also from a cost perspective, to do things better would be great. And those who were against it, who argued kind of against it, argued that it would be quite difficult to drain, that either, from an endoscopy point of view, through the stomach or through the duodenum, I would be very reluctant, that everybody was reluctant and we didn't do it. We didn't drain collections that were not walled off, while the radiologist has no problem at all to drain fluid that is not walled off. So, we ended up with quite a few patients that needed percutaneous drainage, but again, the whole concept did not materialize. So we still are stuck.
What is the reason? So why did the early drainage arm have more re-interventions and all that?
So very often, what we saw in some patients that you did drain one collection, but on follow-up CT, other collections arose that did not communicate with the original collection that we drained. And I think also that's what and in fact, some of the presenters also alluded to that. Sometimes you have very complex collections. And when you look at serial CT scans, over time, you see the collection not only maturing, but also kind of they kind of integrate together. They have confluent characterization, and that makes then drainage over time much more easy because you don't need multiple drainage procedures. You only maybe need one. And that was exactly what we saw. We needed multiple procedures in those patients that we drained early to kind of keep on track draining all the collections that occurred. Unfortunately. Yeah.
That's why you needed a trial. That's interesting.
Yeah.
And I think, you know, the other thing, what I think is good to point out is what I told you about the second trial, where we first saw in that pilot trial this huge success, you know, almost too good to be true, that endoscopic therapy was much, much better than the surgical step-up approach. That if you do a kind of, you know, a good, well-powered, well-designed randomized trials, results are different. So I think that's also a message to our community. Pilot trials are always good to do, but to confirm things and to keep them and take them up into our guidelines, we need randomized controlled trials.
Todd, it's good that you're back because just now during Kelvin's talk, so he mentioned that depending on the anatomy of the collection wall of necrosis, in the AGA paper, they were mentioning recommending both endoscopic as well as laparoscopic necrosectomy. So can you tell us a bit how the discussion went through and how did you ended up having this recommendation?
Yeah, most of the surgical recommendations were made by the surgeon, Catherine Morgan, and probably was experiential based on what she does and her colleagues that do endoscopy. So specifically you're saying as opposed to surgery, as opposed to endoscopy in that regard, or the specific surgical recommendations?
Kevin, can you supplement? I think.
In the surgeon point of view, if the so-called collection, the necrotic pancreatic collection, is only a retrogastric region, of course, the transgastric approach is the best. But say, for example, if there is a multi-location collection, like what Professor Bruno mentioned, that we have to drain multiple sites. Although you can put in multiple stents, multiple lamps, but in my point of view, sometimes a transgastric laparoscopic approach or even the open surgical approach will be the best to take care of all these multiple sites of the collection around the retroperitoneal region. And mind you that not all these collections are interconnected with each other. So if we do it through the endoscopic, we'll have to do the multiple puncture site drainage. So surgeons still have a role for that.
Yeah, Kevin, I enjoyed your talk. In a year, how many patients during your practice are doing open necrosectomy?
Very few. In my practice of year, maybe 4 to 5 need so-called the open necrosectomy. Nowadays, with the endoscopic one, some patients will do the endoscopic drainage.
I think during this necrotizing pancreatitis issue, as you summarized, there has been long debate. At the beginning, early period of surgeons actually did a major role, but the surgeon actually failed to make a good outcome during early phase of necrotizing pancreatitis. And in the beginning period of necrotizing pancreatitis, surgeons emphasized that if we do not surgically intervene this kind of patient, then mortality rate is more than 50%. So famous surgeons actually emphasized immediate surgical intervention is very critical. But later, they confessed their mistake. It was totally mistake, I think. And 10 years later, 15 years later, they understand the natural history of necrotizing pancreatitis. Yes, surgeons can do debridement and can make anatomical derangement by removing necrotic material, but surgeons also created a lot of issues. And because of that, the mortality is still very high. But when we continue medical therapy, then the mortality rate of necrotizing pancreatitis is not 50%, much less than that. Maybe due to improved antibiotics or improved the conservative measure during last 2 decades, 3 decades. Still, I think we need to know that probably minimal approach would be the best for the patient. Because human body try to maintain their homeostasis and they have their natural healing power. It may sound it is not scientific, but we have seen similar the trend or similar phenomenon so many times during our practice. So even for Mark, you mentioned that early period intervention actually failed to show good results after randomized trial. But even before randomized trial, during our practice, we saw many times early intervention definitely cannot make a good outcome. So what I think it is important is we need to, I think, we need to think about the human physiology, human natural barrier, human natural defense mechanism first. And probably we need to do something. I'm not just talking about surgical intervention. Endoscopic intervention is also, I think, same is true for endoscopic intervention. If we try to intervene in the early phase of acute pancreatitis, there is still inflammatory activities going on. And we don't know, as Mark mentioned, this fluid collection is the only thing, or later there can be another fluid collection or necrotic, or there is continuous pancreatic juice leakage. It is not very clear, but in that case, if the patient's condition is not very fatal, then we should not, I think we should not intervene for those kind of cases. It may be my personal prejudice, but that's what I observed during my practice. Todd, good to see you here.
Yeah, great.
Okay, so I think it's getting late, at least for us in Asia. May I request everyone to turn on their cameras to have one final photo shoot. And once again, thank you very much for your very nice lecture, excellent discussion. It's an area which is very exciting. We have more than 700 participants. And thank you very much for your hard work. So can we all smile for Flora? Flora will take a picture. Thank you. Okay.
Bye, guys. Ciao.
Okay. Thank you. Good night.
Bye. Thanks, everyone.
Bye.
Got it. Thank you. Thank you, everyone.
Bye-bye.
Bye-bye. Thank you for your time. Bye-bye.